ring is called a phenol ring. Okay, a hydroxylated benzyl ring is called a phenol ring. Then you have tryptophan, which has your indole ring. Indole ring is a complex ring. It's a heterocyclic structure. It has a heterocyclic structure. Now, out of these, phenylalanine and tryptophan are essential amino acids. What do you mean by essential amino acids? They got to be provided in the diet. The only sole exception is tyrosine. The only sole exception is tyrosine, because we see you can make tyrosine from phenylalanine by means of hydroxylation. If you hydroxylate phenylalanine, then you get tyrosine. So, tyrosine is non-essential. Phenylalanine and tryptophan are essential amino acids. They are partially glucogenic. You will find pyruvate synthesis from tryptophan, and the rest are ketogenic. Okay, they have both glucogenic and ketogenic, because during its metabolism, during its degradation, you will see phenylalanine and tryptophan giving rise to fumarate, and fumarate is an essential part of which cycle? TCA cycle. Okay, fumarate is a part of TCA cycle. Okay, only plants and microorganisms have the ability to synthesize aromatic amino acids. We humans need to get it from diet. See, such an easy structure. Benzene ring, then you get a CH2, CH, NH2, COH, an amino acid group. This is your phenylalanine. This is how it looks like. Now put a hydroxyl group underneath phenylalanine. Put a hydroxyl group at the bottom of phenylalanine, and you get tyrosine. Okay, and tryptophan, as I said, it is a heterocyclic structure. It has a pentane structure along with a benzene ring having an ammonia at its center. Okay, having an amide group at its center. So this is your tryptophan. This is how it looks like. This is how it looks like. Now let us come how they are made. The first pathway is for making tryptophan, tyrosine and phenylalanine, and the biosynthesis starts through the Shikimate pathway. Through the Shikimate pathway. Okay? What happens is phosphoenol pyruvate will undergo a reaction with erythrose 4-phosphate. Phosphoenol pyruvate you get from? Phosphoenol pyruvate you get from where? Yes, and you get erythrose 4-phosphate from HMP shunt. So these two will coalesce to form a Shikimate compound. And this Shikimate compound will be further metabolized to form charismate. From charismate, it divides into two paths. First is anthranilate path, which will give rise to tryptophan, and then you will have prephenate path, which will give rise to tyrosine and phenylalanine. Okay, so let us see how these reactions look like. Phosphoenol pyruvate plus erythrose 4-phosphate, they will undergo a compound reaction to form 2-keto-3-deoxy arabinoheptulozanate phosphate. 2-keto-3-deoxy arabinoheptulozanate 3-phosphate. Okay, and this will further be reduced to form dehydroquinate. It will further be reduced to dehydroquinate. This dehydroquinate will release a water with the help of dehydratase to form dehydroshikimate. This dehydroshikimate will further be reduced by dehydroquinate dehydrogenase to form shikimate proper. Then we have an enzyme called shikimate kinase. and this shikimate chymase will phosphorylate it to shikimate 5-phosphate. It will phosphorylate it to shikimate 5-phosphate. This shikimate 5-phosphate will then again condense with phosphoenol pyruvate to form enyl pyruvate shikimate. Enyl pyruvate shikimate. Then it will lose a phosphorus and will give rise to chorismate. It will lose a phosphorus and give rise to chorismate. Now you are thinking, how are we going to get hold of such a difficult pathway with such structures? You are not expected to remember or draw structures accurately at your UG level. Okay? You should only know the substrate, the enzyme, the reaction, and what it is forming. Okay? That is only what is expected from you. So again, phosphoenol pyruvate and erythrose 4-phosphate will condense to form 2-keto 3-deoxy arabiloheptanosate 7-phosphate with the help of 7-phosphate synthase. Okay? Then it will undergo a reduction with 3-keto arabinoheptulosonate phosphate dehydrogenase to form dihydrocunate. This dihydrocunate will lose water with the help of dehydrocunate hydratase to form dehydroshikimate. Then this dehydroshikimate will be acted upon by a kinase to form dehydroshikimate phosphate. This dehydroshikimate phosphate will then condense again with phosphoenol pyruvate, ultimately giving to chorismate, and from chorismate then you will find the bifurcation. One will give rise to tryptophan and the another set will give rise to phenylalanine and tyrosine. Okay? So let us come to tryptophan synthase. This is a more cumbersome part. So what happens is, tryptophan is synthesized from chorismate in 5 steps. Tryptophan is synthesized from chorismate through 5 steps. First of all, chorismate gains an amino group from glutamine, okay, to form anthranilate. It will get hold of an amine group from glutamine to form anthranilate, and this anthranilate will then condense with PRPP, phosphoribosyl pyrophosphate, to form enol carboxyphenyl amino 1-deoxyribulose 5-phosphate. Okay? As I told you, that names are cumbersome, but there is no other way. Please hold on, because ultimately when we come to the near end of the discussion, there you will have the deficiency diseases, and there we can have some fun. But before you reach that, you have to go through this on and on metabolism. Okay? When I will show you in a pathway form, things will become easier. This is just an overview. Okay? This is just an overview. So tryptophan is synthesized from 5 steps through chorismate. The first part is amination with glutamine to form anthranilate. This anthranilate will then complex with phosphoribosyl pyrophosphate to form enol 1-carboxyl phenyl amino deoxyribosyl 5-phosphate, and then it will transfer itself to a intermediate product. It will convert itself into an intermediate product called indole 3-glycerol phosphate. Indole 3-glycerol phosphate, and ultimately after many reactions you will get hold of tryptophan. Okay? So see, chorismate, there is glutamine, give an amino group, and the pyruvate is lost, and there you have anthranilate. You see the hydroxyl group that was present over here is not here. Okay? The hydroxyl group that was present over here is not here anymore. This is the reaction going on. Okay? And then you have anthranilate, and the first enzyme is anthranilate synthase. The first enzyme is anthranilate synthase, and then it will complex with PRPP to form anthranilate phosphoribosyl pyruvate, anthranilate phosphoribosyl pyruvate. Okay? And then you will have a transferase reaction to form enol carboxyphenol amino deoxyribulose phosphate, and then with further reaction it will become indole 3-glycerol phosphate. After a series of reaction it will become indole 3-glycerol phosphate. This indole 3-glycerol phosphate will again go a synthesis reaction with the help of serine, will undergo a complex reaction with the help of serine in presence of PLP to finally give you tryptophan, So, this is the tryptophan synthesis pathway. Unfortunately, I won't be able to repeat it because we have a large portion to cover. It has already taken 10 minutes. So, let us see now how tyrosine and phenylalanine synthesis occurs. That is also from charismate. Okay. So, from first phenylalanine from charismate came through anthranilate, right. Here the precursor is prephenate. Okay. The mutase converts charismate into prephenate. Okay. This prephenate can be oxidatively decarboxylated to p-hydroxyphenyl pyruvate. Okay, to p-hydroxyphenyl pyruvate. Then both of them are decarboxylated. Okay, both of them are decarboxylated to yield phenyl pyruvate. Then this phenyl pyruvate is again transaminated. It is again transaminated to form phenylalanine and tyrosine. It is again transaminated to form phenylalanine or tyrosine. Now, let us have a look how that occurs. See, charismate mutase. Here is the charismate mutase. This is your prephenate. This prephenate will undergo dehydrogenation with the help of prephenate dehydrogenase. Okay, prephenate dehydrogenase to form hydroxyphenyl pyruvate. And this hydroxyphenyl pyruvate will undergo transamination with glutamate to alpha ketoglutarate to give you tyrosine. So, what is happening, you can see this COOH has to be removed. In order to remove this CO minus, you had pyruvate dehydrogenase and decarboxylation, and you have hydroxyphenyl pyruvate. This portion is hydroxyphenyl pyruvate. Okay. This hydroxyphenyl pyruvate then got transaminated to the carbon that is linked to the carboxyl group to form tyrosine. The same thing is occurring here also. Here you had prephenate dehydrogenase. You see, carbon dioxide was released. Here through prephenate hydratase, then again it was released. See, the difference between tyrosine and phenylalanine is just with the OH at the below. So, in order to come through this path, what it did is, instead of dehydrogenasing it and removing the CO2, it removed the water molecule as well. That is why you do not have this OH. And this is your phenylalanine and this is your tyrosine. Put a OH on phenylalanine and you got tyrosine. That is why it is non-essential. Are we clear? So, shikimate, charismate, anthranilate, phenyl pyruvate, and from there you get tryptophan. On the other hand, charismate, prephenate will further undergo, first there will be dehydration, there will be loss of water and a carbon dioxide, and then there will be transamination to form phenylalanine. So, this is the synthesis of the out of the 3 essential aromatic amino acids. Now, tyrosine can be also made by animals directly from phenylalanine via hydroxylation at C4. What I was saying, just put a hydroxyl group there and you have got tyrosine. Okay? And this phenylalanine hydroxylase also takes part in degradation of phenylalanine. In order to undergo this dehydroxylation reaction, you need a donor, and that donor is tetrahydrobiopterin. That donor is tetrahydrobiopterin. Okay? So, dihydrobiopterin is first reduced to tetrahydrobiopterin by NADH, and then this electron donation occurs. See how. This is your phenylalanine, this is your tyrosine. You need to put a hydroxyl group over there. So, you are using phenylalanine hydroxylase, which will cause O2 to H2O, and the supportive structure is tetrahydrobiopterin, which is getting reduced to dihydrobiopterin in order to donate the hydroxyl group that is not present in phenylalanine. Okay? And if this particular enzyme is absent, then this becomes phenylketonuria. Okay? Phenylalanine hydroxylase, if it is not there, it becomes phenylketonuria. Okay? Chalo. Now let us say how it is broken. If you have made something, you have to break it as well. Very common with boys. Okay? The first, as soon as we get a toy, our first instance is see how the mechanism works. Okay? Try to find where the screws are there. Make it a little loose, see if you get a little more maneuverability, right? You have done it? Don't think so. You are like the goody boy mascot of the class, you know, good boys. I was unfortunately one of the backbenches in my days, because I was damn afraid of my teachers. Okay. So let's see how the aromatic amino acids are degraded. In order to degrade it, you have to do a decyclization. You have to do a decyclization. You have to break up a cyclic ring, which is very difficult because cyclic structures are stable or unstable? Stable. Stable, because cyclic structures are stable. So what happens is tyrosine is, see, there is a beautiful benzyl ring, then you have a beautiful hydroxyl group, and then you have a amino group attached to it. Nothing very difficult. Nothing very difficult. Okay? You see, I can draw it for you. Okay, benzene ring, happy? CH2, NH2, COH. Easy. Put a hydroxyl over here. This becomes tyrosine. Now come to phenylalanine. This is a heterocyclic compound, right? Okay. Put again benzene. Okay. Shade. And then from here CH2, same structure. CH. Drawing is not difficult. At least drawing it is not difficult at all. But you have to got to practice it like a little bit like me. Okay? Otherwise it might become cumbersome. Okay, so first is tyrosine. Then you have tyrosine transaminase. Alpha ketoglutarate to glutamate. Okay? And then you have lost the ammonia group that is present over here. The ammonium group is gone. So if the ammonia is gone, and if this is basically phenyl pyruvate, now this is basically phenyl pyruvate, and due to the hydroxyl group present, it is hydroxyphenyl pyruvate. Due to the presence of hydroxyphenyl pyruvate. Okay? Because the amino acid group has been taken out with the help of transamination, so easy. Okay? This alpha ketoglutarate took out this ammonium group to form hydroxyphenyl pyruvate. Now you have to break the ring open. You got to break the ring open. In order to do so, what you did is you dehydrogenased it, or sorry, you oxygenased it with the help of a dioxygenase. You oxygenated it with the help of a dioxygenase. So hydroxyphosphoenol pyruvate dioxygenase. Hydroxyphenyl pyruvate dioxygenase will break up the ring and give you homogentisate. It will break the ring up and give you homogentisate. Then you again break up the homogentisate as well. So for that you again use oxidation. So the enzyme is homogentisate. Tell me, in order to put oxygen, what do you use? Homogentisate oxidase. Okay, homogentisate oxidase. Once you use this, break up this homogentisate, with the help of homogentisate oxidase, you get a mallyl acetoacetate. You get a mallyl acetoacetate. After this, all is isomerization. After this, entire thing is isomerization. This mallyl acetoacetate will undergo isomerization to form fumaryl acetoacetate. And then you have a fumaryl acetoacetate, which will break this fumarate and an acetate. So what kind of amino acid has this become? It has given you an acetate. It will go to, acetate goes to ketone body formation, acetoacetate, right? And fumarate will go to TCA cycle. So this is both glucogenic and ketogenic. This is both glucogenic and ketogenic. So easy. First of all, there is tyrosine, which is nothing but a benzyne ring having a hydroxyl group and having a amide group. Now remove this amino group with transamination, with the help of tyrosine transamination. So this has become a hydroxyphenyl pyruvate. Then you oxidize that hydroxyphenyl pyruvate and you break the ring. And you have got homogentisate. Then again break the homogentisate with the help of oxidase, homogentisate oxidase, and you get a mallyl acetoacetate. Then it will rechange itself into a fumaryl acetoacetate. Then you have a breaking down, fumaryl acetoacetate, and it will broken down into acetate and fumarate. Fumarate will go to TCA cycle, glucogenic. Acetate will go to ketogenic pathway. So this is both glucogenic and ketogenic. So easy. Then comes tryptophan. I really don't like this pathway. I really don't like the tryptophan pathway. I still cannot remember it. It's very cumbersome for me. I hope you land up in a different boat than mine. See tryptophan, here you have tryptophan pyrrolase. You have got tryptophan pyrrolase. Why do you have pyrrolase? High power oxidation to break the ring. And here you will get formyl kynurenine. Tryptophan acted upon tryptophan pyrrolase will give you formyl kynurenine. Then you have a kynurenidase, which will give you kynurenine. Now this kynurenine will be dehydrogenased with the help of NADPH, and that will give you hydroxykynurenine. This hydroxykynurenine will again be acted upon kynureninase, to give you alanine and 3-hydroxyantranilate. Now this 3-hydroxyantranilate will again undergo oxidation with the help of dioxygenase enzyme. It will again undergo oxidation from dioxygenase enzyme to form a amino carboxymuconate semialdehyde. Amino carboxymuconate semialdehyde. If you cannot remember, just write semialdehyde and be done with it. Okay? If you cannot remember, just write semialdehyde. Okay, done. We are happy. Okay? Just write semialdehyde. Okay? So this semialdehyde will again undergo 10 to 11 steps, ultimately giving you acetoacetate. So this is what? Glucogenic or ketogenic? This is glucogenic or ketogenic? Both you idiots, you get alanine out of it. You get alanine out of it at the chironinase step. And that alanine will give you pyruvate. So it is both glucogenic and ketogenic. Okay, have the entire picture. Okay, have the entire picture. So this is about the tryptophan hydroxylation. Suppose you do not remember anything. Just remember tryptophan pyrrolase. Kynurenine hydrogenation of kynurenine hydroxylase. Okay. After kynurenine hydroxygenase, remember kynureninase that gave you alanine. Remember kynureninase which gave you alanine. And after that you get a semialdehyde. Now this semialdehyde will undergo various reactions, ultimately leading to acetoacetate. Okay. That is how this is supposed to work. So we are done with the tryptophan degeneration. It is not over, only 30% of it is over. Okay, only 30% of it is over. Now we have amino acids as metabolic precursors. This is the main part. This is what is the most important part. Why are we so emphasizing on tryptophan, tyrosine? What actually they are doing in the body? Okay. So first of all, tyrosine is an important precursor to signal transducers neurotransmission. Okay. Let's see why. Tyrosine is oxidized by tyrosine hydroxylase to form L-DOPA or levodopa. Okay. Tyrosine hydroxylase, again tetrahydrobiopterin got reduced to dihydrobiopterin to form L-DOPA. Okay. This L-DOPA will be decarboxylated with the help of dopamine, L-DOPA carboxylase to give you dopamine. Now this dopamine, if methylated, becomes written over there. This dopamine, when it gets methylated, you get epinephrine. You get norepinephrine. Okay, you get norepinephrine. Okay, and this norepinephrine will give you ultimately epinephrine. What are these molecules? Dopamine, norepinephrine. Yes. Okay, they play neurotransmitter role in your sympathetic pathway. Remember sympathetic and parasympathetic? What are your neurotransmitters for sympathetic pathway? Adrenaline, noradrenaline, dopamine and epinephrine, metanephrine. And for parasympathetic you have got parasympathetic, acetylcholine. So these are basically neurotransmitters. They are regulating everything, right from blood pressure, starting from blood pressure to heart rate to everything, sympathomimetic activity, and this is how these molecules are produced. Tyrosine. Then you have got a tyrosine hydroxylase. Remove the OH group. Remove the OH group. You have got what? You have got dopa, L-DOPA, levodopa. You have got a levodopa. Then you reduce it. Okay. Then you decarboxylate it. Remove the carbon dioxide with the help of PLP and you get dopamine. Then you dehydrogenase that dopamine to form norepinephrine. Then you methylate that norepinephrine in order to get epinephrine. You see tyrosine hydroxylase remove this OH. Okay, there is another OH over here. এখানে ছিল 4 নম্বরে 5 নম্বরে আরেকটা OH এলো. So you get dopamine. Now remove this CO minus L-DOPA, levodopa, remove this CO minus, you get dopamine. তার মানে cyclic ring, 2 hydroxyl and 1 amino group, the carboxyl group has already been removed. Then once you dehydrogenase it, that means this CH2 here will have a OH group. See here, you have hydroxylated it, and then you put a methyl over here in this carbon. You put a methyl over here in this carbon and you get epinephrine. So all of these are necessary for alpha sympathomimetic action. All of these are necessary for alpha sympathomimetic action. You see here the acceptor is epinephrine, sorry, the acceptor is epinephrine and acceptor is norepinephrine and it will become epinephrine. You see the acceptor is basically your norepinephrine, it will become epinephrine. How? Because this phosphoribosyl methionine will give you a methyl group to give you adenosyl homocysteine and the methylated acceptor is epinephrine. Okay. So now tyrosine also gives us colors, pigments, okay, and they are precursor, the precursor is dopaquinone. The precursor is dopaquinone and this precursor of dopaquinone will either give you eumelanins which are dark and brown pigments, or you have pheomelanins that have red or yellow colored pigment. Okay. You have got eumelanins and pheomelanins. Now the yellowish color actually comes from the sulfurin cysteine that is used in combination to dopaquinone. You do not need to remember this metabolic pathway. Okay, just remember that tyrosine is precursor of eumelanin and pheomelanin. Then comes finally thyroid hormones. Okay, thyroid hormones. The tyrosine residues that are present in the thyroglobin proteins that is present in thyroglobin proteins are iodinated to form MIT, that is monoiodothyronine, diiodothyronine and tetraiodothyronine. When the stimulation comes, this tetraiodothyronine will give you T4 and this T4 will be recyclized to T3 at the tissue level. Okay. So tyrosine is also the precursor for the thyroid hormones in the body. Very good. So once again repeat, what do we get from tyrosine? First is dopamine, then we get norepinephrine, then we get epinephrine, then we get pigments, pheomelanin, eumelanin and finally thyroxine. Okay. So these are the things that are synthesized from your tyrosine. Now come to tryptophan. The important part is serotonin. The important part is serotonin and melatonin. Niacin is a byproduct. Okay. The important part is serotonin and melatonin. Serotonin is a inhibitory neurotransmitter in your brains and melatonin causes pigmentation of your skin tissues. Okay. It causes pigmentation of skin tissues. Now see tryptophan hydroxylase. You put a hydroxyl group over tryptophan, you get 5-hydroxytryptophan. Now you remove the COH group from over here. You get 5-hydroxytryptamine, 5-HT. Okay, you get 5-hydroxytryptamine, that is 5-HT, also called as serotonin. Very easy. Phenylalanine hydroxylase. Put a OH group at the 4th carbon. Then you decarboxylate it and remove the COH group out of here and you get 5-hydroxytryptamine. You get a 5-hydroxytryptamine which is nothing but serotonin. Now this 5-hydroxytryptamine is worked upon by N-acetyl transferase and O-methyl indoxyl methyl transferase to form melatonin. And melatonin, what it is? What is melatonin? It's a skin pigment. Okay, you idiots. Melatonin is a neurotransmitter that helps you in your RAS cycle and sleep wake cycle. Melatonin is not your skin pigment, melanin is. Okay. Your body sleep cycle is being maintained by melatonin. It is not melanin. Okay, it is a part of the limbic system. I am also teaching you physiology, and you are still not being able to answer. Okay. So, serotonin is a negative in neurotransmitter and melatonin is for your sleep awake cycle. Both of these drugs, both of these neurotransmitters are usually inhibited to find very good results in case of depression patients. In case of depression patients, you have SSRI, selective serotonin reuptake inhibitors, that you give for major depression. You give melatonin injections to those people who are not able to sleep at all. Okay? So, these things will come, and niacin, you know, niacin is vitamin B3, very good, vitamin B3. So, hydroxynolic acid, quinolic acid, then further reacted by QPRT, that is quinoline pyrophosphate phosphoribosyl transferase. Don't look at me as if I am talking in Hebrew. These are all Latin. Okay, quinoline phosphoribosyl, quinoline pyrophosphate phosphoribosyl transferase, and that will give you NMN nicotine mononucleotide, put a ATP dinucleotide, and then finally you will get NADP. Then you will get NADP. So, NADPH we used to get from NADPH we get from HMP shunt. Where do you get NADH from? Quinolinate pathway of phenylalanine. Okay, quinolinate pathway of phenylalanine. Pay attention, we are only 50% done, much is left. Okay, so the precursor of tyrosine, once again, precursors of tyrosine, precursors, tell me quick. Tryptophan, those are, I am talking about tyrosine, come on. Dopamine, norepinephrine, epinephrine, thyroxine, phenylmelanin, eumelanin. What do we get from tryptophan? Serotonin, melatonin and niacin. Okay, and this niacin is giving you the most important reducing equivalent of your entire ETC cycle. Okay, no phenylalanine, no ETC. That's how much important it is. No phenylalanine, no ETC. If there is no ETC, you are dead. If there is no ETC, you are dead. Okay, that is the bottom line of cellular respiration. Okay. Now let us come to inborn errors of metabolism. First of it is alkaptonuria, and this happens due to the absence of enzyme homogentisate oxidase. Where did we find homogentisate oxidase? Breakdown of what? Tyrosine or tryptophan? Yes, breakdown of tyrosine. First there is tyrosine. Remove the OH group, then remove the amide group, and then finally use homogentisate oxidase to put an oxygen and then again break it further. You will get a mallyl acetoacetate. That mallyl acetoacetate will rearrange itself to form fumaryl acetoacetate, and that fumaryl acetoacetate you use fumaryl acetoacetate to break it down into fumarate and acetoacetate. Acetoacetate is ketogenic, fumarate is glucogenic. Clear? Easy peasy chicken sleazy. Okay. So what happens in alkaptonuria? The homogentisate oxidase that you got due to metabolism of tyrosine cannot be further broken down. Okay, the homogentisate that you got from the breakdown of tyrosine cannot be further broken down. So what happens is this homogentisate starts accumulating in your body. It starts accumulating into your body, and it has a pristine black color. It has a pristine black color. So in children, specifically with sweat, you will see black coloration in the diapers, and in adults there will be black pigmentation in and around the sclera of eyes here. Now please do not confuse it with a nevus. Okay. Next, in your ophthalmology classes, if a teacher tells you what it is, do not cry out, sir, this is alkaptonuria. No. Okay. Do not confuse it with a nevus. And the pigment differentiation cannot be differentiated until and unless you are slitting in a slit lamp. You will know what is a slit lamp. Okay. So it turns, and this particular turns black upon color exposure to urine. So when you have taken the urine sample of a patient, you have put it into room temperature, after 2 or 3 hours you see it has turned black. So that is why it is called alkaptonuria. That is why it is called alkaptonuria, and this is due to the deficiency of the enzyme homogentisate oxidase. Homogentisate oxidase. Now, what are its chief clinical features in adults? Okay. You will have mainly arthritis. You will have mainly arthritis because this homogentisate crystals will get deposited in your joints. You will find all assuming arthritis. It is not that you will only find it in the knee joint or you will only find it as in hip joint. Okay. You will find it in every joint. You will find it in every joint. See, phenylalanine hydroxylase, it gives you tyrosine. Tyrosine transaminase, it gives you hydroxyphenyl pyruvic acid. Hydroxyphenyl pyruvic acid oxidase will give you homogentistic 2-hydroxyphenyl acetic acid. This will give you myeloacetic acid, and here comes your enzyme homogentisic acid oxidase. Alkaptonuria, this enzyme is blocked. Okay. In alkaptonuria, this enzyme is blocked. So, this homogentisic acid will first of all start increasing in your blood levels, and then it will start getting deposited in your tissues. Okay. Where will it deposit? It will deposit around the skin, it will deposit in the white of your sclera, and it will be diffusing inside your joints, causing arthritis. Clear? Clear? Very good. So now we are done with alkaptonuria. Then we have got phenylketonuria. It is a genetic defect in gene coding phenylalanine hydroxylase. Genetic defect in the coding of the enzyme phenylalanine hydroxylase. Okay. What does it cause? Defect in myelination of nerves. Brain weight is below normal. Mental and physical retardation and severely decreased life expectancy. Okay. And severely decreased life expectancy. How do you diagnose it? High levels of increased phenylalanine levels in your blood, and then you have ferric chloride test. Okay. When this excess of phenylalanine will react, or phenyl pyruvate and phenyl lactate will react with ferric chloride to give you a green color. And then you have prenatal diagnostics. With the help of DNA probes, you can match up the entire genome. The patient is having phenylketonuria due to the absence of phenylalanine hydroxylase. What does phenylalanine hydroxylase do? Yes, phenylalanine to tyrosine. Phenylalanine hydroxylase puts a OH in the fourth carbon of your phenylalanine. Okay. This entirely is phenylalanine without this hydroxylase group. Okay. Now this phenylalanine hydroxylase will put a OH over there, converting phenylalanine into tyrosine. Come on, people. Pay attention. You are losing it. Okay. You are losing it. You are not supposed to lose it. You are going to bear through the entire lecture and look at me as if you understood everything, though you understood nothing, and that is going to leave me a very happy and satisfied man. Okay. So now how do you treat? See, treatment of phenylketonuria is very important. Treatment of phenylketonuria is very important because this occurs specifically in children. This occurs specifically in children, and there is a lot of adverse effect and mental retardation. The good thing is the entire thing can be reverted. The good thing is the entire thing can be reverted if you can make the diagnosis. So how do you revert it? You restrict phenylalanine doses in food and you supplement tyrosine. Okay, you restrict phenylalanine doses in food and you supplement tyrosine in food so that the tyrosine pathway can run unhampered. The tyrosine pathway can run unhampered. Okay. What are the clinical symptoms of phenylketonuria? See, dietary amino acids, this is your phenylalanine. There is no phenylalanine hydroxylase, there is no tyrosine. So what will happen is this phenylalanine will undergo a transamination. The amino group will be removed and you will get phenyl pyruvate, and this phenyl pyruvate will give you further phenyl acetate and phenyl lactate. And this phenyl lactate and phenyl acetate will get excreted in the sweat of the baby, and it will give you a characteristic cabbage order sweat. Cabbage ordered sweat. Okay. So that is the of phenylketonuria. Okay. And the biggest thing is due to the absence of what? Tyrosine, there is very much reduced amount of epinephrine, norepinephrine, which will cause demyelination. It will cause demyelination and mental retardation in case of small children. Okay, it will cause mental retardation in your small children. What happens is after birth, about 3 to 6 months, the baby is fine. Then it will start losing its developmental milestones. Then comes to the diagnosis of phenylketonuria, that why the patient is degenerating. This is a reversible cause. Okay, this is a reversible cause. NutraSweet, you see, packed foods have aspartame. Aspartame is usually used as a food preservative. Okay, this aspartame is absolutely contraindicated in case of phenylketonuria patients. Okay, so if you ever find a phenylketonuria patient, always counsel them not to take packed food. Always ask them to take freshly cooked food as meals. Okay. Then finally is albinism, and albinism is due to the lack of the tyrosinase enzyme. Tyrosinase enzyme. Okay. Specifically, the tyrosinase that is present in the melanocytes. Where do you have your melanocytes? Where do you have your melanocytes? Bolo? Yes, exactly. They are present in the basement membrane of your skin. They are present in basement membrane of your skin, and they cause pigment production. Why is this pigment production important? Why is the pigment production important? What role does it play? Why nature took such pains to make such a cumbersome pathway? So that it could make your lives difficult? Of course not. So there must have been a reason. What's the reason? Yes, UV protection. Okay, the basic reason is UV protection, because UV light degrades your DNA. Okay, degrades your DNA, it unpacks your histones and causes free radical damage in your DNA, causing mutations. That is why your skin pigment is so much necessary. So there are three types of tyrosinemias. There are three types of tyrosinemias. Okay, just remember tyrosinase deficiency, that is more than sufficient. Okay, what are the symptoms of albinism? Inhibition of production and lack of melanin in skin and hair. Lack of melanin production in skin and hair. Increased sensitivity to sunlight. Increased sensitivity and propensity to skin cancers. Photophobia, sunburns, vertigo, nystagmus and diplopia. Vertigo, sunburns, photophobia, nystagmus and also decreased vision acuity. Also decreased vision acuity. So this is the third inborn of error of metabolism disease, and that is albinism, and this is caused by the deficiency of enzyme tyrosinase. Now comes tyrosinemia. Now comes tyrosinemia. Okay? Now comes tyrosinemia. It is nothing but a deficiency disease of enzymes. There are three types of tyrosinemias. There are three types of tyrosinemias. Tyrosinemia 1, 2 and 3. Okay, tyrosinemia 1, 2 and 3. Whenever you remember tyrosinemia, remember foot up. Whenever you think of tyrosinemia, remember foot up. Why? Because hypertyrosinemia 1 is the last enzyme, that is fumarate acetoacetate. Hypertyrosinemia type 1 is the last enzyme of tyrosine metabolism, and that is fumarate, which breaks fumarate into fumarate and acetoacetate. Okay, then you have got type 2. Then you have got type 2, that is 4-hydroxyphenyl pyruvate to homogentisate, and that is nothing but hydroxyphenyl pyruvate decarboxylase. Hydroxyphenyl pyruvate decarboxylase, that is your hypertyrosinemia type 2, and type 1 is tyrosinase deficiency. Okay, type 1 is again tyrosinase deficiency. So these are your three hypertyrosinemias. Okay, so what happens is there is increased amount of tyrosine levels in the body. There is increased amount of tyrosine levels in the body, and that will give to hydroxyphenyl pyruvate, lactate and acetate deposition in your body, and increased excretion of tyrosine in your urine, that is called tylosyluria. That is called tylosyluria. Okay. So with this we have traversed the long and difficult road of aromatic amino acids. It is a diktat to you, not a suggestion. When today after your evening hours, read this entire chapter 10 times. Not one time, not two times, not three times, 10 times read it. 10 times. 10 বার প্রথম থেকে শেষ অবধি এই তিনটা অ্যামাইনো অ্যাসিড পড়বে। You will be able to retain it. If you do not do that, tomorrow you will be washed out, you will remember nothing. This is a very difficult portion of biochemistry. Okay, go read it 10 times. Might be boring, might be irritating. Read it 10 times. You will carry these 4 diseases with you in your examination hall when you are sitting for paper 1. Okay, thank you ladies and gentlemen for your patient hearing.
Is a main culprit of many of us disease nowadays we are seeing in the OPDs and IPDs. That may be cardiovascular diseases like the stroke, angina pectoris, atherosclerosis. Already you heard the term atherosclerosis. Yes, atherosclerosis means the lipid or cholesterol, the deposition in the coronary arteries, and that may cause the sudden cardiac death is occurring in young age also. They all are depends upon the genetic factors, definitely, but also it maintains or it regulates our lifestyle. But now you have to understand what is the pre-diabetic and what is the diabetes mellitus by written in your book, that is the oral glucose tolerance test. Have you heard the term? Oral glucose tolerance test, very important. Oral glucose tolerance test, right? Oral means that after the consumption of 75 gram of glucose, 2 hours later we have to check some parameters whether patients having established diabetes or pre-diabetes is very much important. So some levels are important. It is written in your book. It's not so much important to write down here. Still, 100 patients, right? And another is suppose the normal level DL, right? So in this case, this is the normal pattern, and this is the pre-diabetic phase, and that is the diabetic established, right? So any patients after the glucose organoleptic test is established, but unfortunately, or you can say the nowadays the too much important tests have been come to we oftenly done nowadays. But still, if you are a first year MBBS class, you have to understand what was the test before entirely done. এখনো এগুলো করা হয়, but still we have some right. Glycated hemoglobin means hemoglobin is connected with the glucose level. So on a level of and 5. So 6.5 and 5.7 is a range. So it's pre-diabetic. Probably me, I am in this range. There are very different types of risk factors. So I have changed my lifestyle. Probably you have noticed for the first class and the second class, I lose my down 6 kg in the 2 months. Okay, so this is due to my low carbohydrate, almost nil carbohydrate in my fat, in my diet. So this is the diabetic phase. It is seen obvious or not? Not. So this is a belly fat is the main culprit. That is the central obesity. I am coming later. So these things are very much important. If you any patients of your relative, if you prescribe the HB1AC to check, it means the 3 months interval patient is suffering from diabetes. So this important test are nowadays done. There is a HB1AC to identify the risk factor or patients having pre-diabetic phase or in diabetic phase or for the how much period. This test is doing for the 3 months level. তার মানে এইটা যদি বেড়ে থাকে more than 6.5, তার মানে তার 3 মাসের রেজাল্ট আমাকে দিচ্ছে. It gives the prior the result is giving now more than 6.5 is BBB very very alert. So that means already we have established the diabetes mellitus, right? So diabetes mellitus developed in the phase of hyperinsulinemia. So you can now cross the questions that in case of diabetes type 2 mellitus, oftenly clinician use the insulin to maintain the sugar level, right? So that is a contradictory. In your blood, that is a hyperinsulin level ta bere ache, but still you are giving the insulin to reduce the glucose level. That is not the right thing. So clinician or we are much giving the burden of the insulin in our body, and ultimately insulin resistance already developed so that patients having diabetes mellitus, right? Insulin resistance na howa porjonto diabetes mellitus hobe na. So the two terms now are coming, there is a hyperinsulinemia and the insulin resistance. All are related. That means a coin. If you see one coin, the one side of coin is hyperinsulinemia and another part of the coin is insulin resistance, right? So it is a thin process that before doing any glucose level test, oral glucose test, you have to understand what to do about the fasting insulin level or the C-peptide level must be done. And nowadays it is done by the good clinicians or some of the in the outside also, in the UK and America, this is now dictum, because insulin level high, insulin resistance is catastrophe into the landed into the metabolic syndrome. It is present in your syllabus, right? Metabolic syndrome, it is present in your syllabus. So oral glucose tolerance test nowadays often is not done oftenly. It creates some confusion also. Fasting ke ache ki nahi, on 12 hours fasting is important for the test, but you can do the HbA1c to predict whether patients having some normal level, pre-diabetic level or a diabetes level. That is the HbA1c, that is glycated hemoglobin level. Now you already know that the cause of insulin resistance are mainly the three. There is a hyperinsulinemia, number 2 is the stress, and number 3 is, yes, that is the inflammations. Already I described the inflammations during the descriptions of inflammations. We already know that each and every of your students, including me, have some personal fat threshold. That means what is happening here, that is the subcutaneous tissue until you are gaining fat. আমি খাচ্ছি, তুই খাচ্ছিস, সবাই খাচ্ছিস, বিরিয়ানি খাচ্ছিস, আমরাও খাচ্ছি, until it is going into the subcutaneous fat, it is okay. But the accumulation of fat in the subcutaneous tissue is individual to individual, dependent by the genetic factor and presence of P adipocytes, already mentioned already. So whenever the subcutaneous fat is saturated, then it will spill over the visceral fat. Visceral fat means fats around the organ. And another term that is the ectopic fat. That means the fat deposition into the organs. That is much more dangerous, right? So fatty liver is nowadays an important predicting factor. The patients may come into the having already insulin resistance, right? For the insulin resistance test, for the detect, one test nowadays is done, that metabolic assessment of insulin resistance. How does it done? It's a formula is that fasting sugar the HOMA IR for detections of our insulin resistance. So insulin resistance nowadays we can calculate in your family members. It is done. এটা করা হওয়া খুব easy, কোনো ব্যাপার না. Fasting sugar we can detect. The problem is that the unit. Some country may use the fasting insulin in the millimole. তাহলে এইখানটা চেঞ্জ হয়ে যায়, এইখানটা চেঞ্জ হয়ে যাবে 22.5 if it is millimole per liter, right? The insulin fasting level in unit millimole per liter হয়, divided by 405 এর জায়গায় হয়ে যাবে 22.5. মনে রাখতে পারলে মনে রাখ, otherwise it never ever will asked in your viva exam, nobody by any seniors or any examiner. It's not for your exam. I'm already telling you that's only for knowledge, because insulin resistance is nowadays going through your pharmacology, medicines, everything. You can get this such type of problems. So fasting sugar, fasting insulin level divided for 405 if the fasting insulin level units is micro unit per ml. But if it is unit is millimole per liter, then that will be divided by 22.5. That is the HOMA IR. That is done. We can get and we can identify, and patient's lifestyle we can change. After identification of the insulin resistance, আমরা একটা পেশেন্টকে বুঝে নিলাম যে insulin resistance develop করছে. The levels, it is mostly level we can say that we are safe. If it is more than 1.5, then it is gradually it is going to the insulin resistance. Right. It is 7. Much more is that. So in these cases, or 8, 9 is much more resistance already developed. Suppose this patient is 1.5 or 2.5, so little bit more. So we can predict the patients may have some common diabetes mellitus after few years. So we can warn them. Say, why? Tomra lifestyle change karo, insulin resistance toma start hoye geche. What does it mean? Insulin resistance means chronic inflammation already start in your fat tissue. Fat is the only cells, fat tissue or adipose tissue is the first site for the development of the insulin resistance. Remember that. Fat cells and adipose tissue are the first site where the insulin resistance appears fastly. So this is a much important, and your family members also, whether suffering for whether patients having already insulin resistance or not. মনে করতে ডায়াবেটিস নেই, কিছু নেই, ডায়াবেটিস দেখে কিভাবে না শুধু সুগার দেখা হয়, but you don't know about the insulin level. You don't know. If it is hyperinsulinemia, that means patient is going towards the insulin resistance. Hyperinsulinemia is one of the important and biggest cause of the insulin resistance after the stress and inflammations, and that is a chronic low-grade inflammation already done. So to detect the chronic low-grade inflammations, I already mentioned in previous class that CRP level is important to check, but not in our CRP. In our CRP means C-reactive protein in the CBCs, already we done, but that is not done in the to know the low-grade inflammation. That is a high sensitivity CRP is checked, and it is done in good labs to check whether যখন আমি করি আমার পজিটিভ আসবে, it is the range is there, definitely it is less than আমার এখানে 1 আছে, that means we already develop in the chronic inflammations and insulin resistance and going towards the diabetes mellitus, but not now. So I checked my lifestyle, so it is to know for your lifestyle also. What do you mean by lifestyle? Lifestyle means everything. Lifestyle means stress, anxiety, feeding, unnecessary smoking, alcohols is each and every. Often you are taking the 1 or monthly for 6-month interval, you are taking alcohols to some 1 to 2 packs is not a harmful for you. But you are regularly going in the hostel and someone is taking, আমরা তো এখন MBBS পেয়ে গেছি, দারুণ একটা, এখন আমরা ডাক্তার হয়ে গেছি. No, don't do that. Your age is around 20, 22. After the 20 years, you will develop, and after the 10 years, 15 years, you will develop hyperinsulinemia, not now. And then ultimately insulin resistance, and that's landed into the metabolic syndrome. And it is happening in day to day, in each and every family has some metabolic syndrome problem. Right? So fat cells are very much important. We already described there is a hypertrophy and hyperplasia. Until the fat cell in a level of hyperplasia, manaki it's okay. ততক্ষণ পর্যন্ত আমরা ভালো আছি, but whenever the arteries and flows like that, and this portion is hypoxic due to the lack of vascular supply, and after the vascular supply compromised, then the cell will die. After the dying that, for the angiogenesis formations, the fat cell releases the pro-inflammatory cytokines, mainly TNF alpha and interleukin 6, mainly TNF alpha, T1 necrosis factor alpha and interleukin 6 is released by the cells. Now these inflammatory markers goes as a chronic inflammatory markers and goes the different organs of our body, not only in the fats, and that changes rapidly to the chemical insulin resistance to the other organs like liver, like muscles, and also alpha cells of the pancreas. This is very much important. Alpha cells of pancreas released glucagon, so it depends insulin resistance. Normally কি হওয়া উচিত, ইনসুলিন যখন বেরোয় তখন ইনসুলিন সাপ্রেস দ্য গ্লুকাগন, বাই তুই বেরোস না, because to maintain the whenever it is insulin resistance, then there is no effect of insulin inhibitory insulin effect on the glucagon. The glucagon বেড়ে আছে, insulin বেড়ে আছে. That means what? What is happening here? Glucagon কি করে? Glucagon causes the gluconeogenesis in the liver. So it promoting the glucose ঢালছে. আর এদিকে লিভারে ইনসুলিন resistance, that is also not taking glucose. The glucose is going up. So whenever you are dealing with the glucose level is 600, 300, already you are having the hyperinsulinemia and insulin resistance already done. So after the fat cells is resistance into the muscle cells, liver and alpha cells of the pancreas is very much important. So hyperplasia is the safest site, safest zone. Hypertrophy of the fat is not encourageable. কখনোই এটাকে এনকারেজ করা যাবে না. This is the important and foremost things are there. Fat, whenever you are eating the fat, where it is going? কোথায় যাচ্ছে? It's going everywhere. But until unless it is fat releases collections as a triglyceride in the fatty tissue and the adipose tissue, right? In the liver also, we already described in the third class that how from the taking the glycerin and the fatty acid, liver is engaging for the formation of the triglyceride, and then also VLDL. Then VLDL carries this triglyceride into the blood. Then this triglyceride is deposited in the fatty tissue, and then this VLDL is converted into LDL cholesterol. You already in the biochemistry class, right? What does mean the LDL, VLDL? Lipoproteins. What does it mean that the very dose lipoprotein and this? Do you know any ideas? What are the structure of lipoproteins? Anyone? Lipoprotein means what? পড়ানো হয়নি lipoproteins? Okay. To some extent, that is the suppose for lipoproteins. Remember always, N is a very protein means density means what? Density means the presence of triglyceride. যার যত triglycerides বেশি তার density বেশি. Nowadays is a low density lipoprotein is much more riskier than the VLDL and HDL, right? If LDL cholesterol is an increasing level, then you can predict the patients may come into the atherosclerotic plaques formations and thrombotic embolism can form. So this is a lipoprotein structure, triglyceride. Whenever it is a VLDL in the liver form from triglyceride, it is a cholesterol. All the periphery it is a cholesterol and it is a protein part that is called lipoprotein, right? So these things are very much important. When it is VLDL, it stands for LDL. That means it has some cholesterol, and also LDL, VLDL, IDL, these are formed from the liver, but exception is the HDL. HDL is not formed from the liver. Suppose it is not here beyond the class because already is the biochemistry part. I'm not going details into this, but these things are very much important and written in your Harper biochemistry very clearly. I can remember the 5 to 6 pages having this. I am also doing the structure by remembering my old memories, that is a triglyceride structure was like that. Triglyceride, cholesterol and this. The Harper's biochemistry lipoprotein chapter is excellent. It's to some extent is a high grade, but you can remember for your whole life. Anyway, so until this way you can understand that whenever a patient is dealing with diabetes mellitus established, that means patients having insulin, hyperinsulin level as well as insulin resistance, right? Now, a patient, suppose Mr. X, suppose in your exam, hypertension. So these scenarios are coming in your OPDs, and you can come across with such patients every day in your family also. To some extent you can get this. Whenever patients having a patient, suppose 48 of age, suppose a male patients OPD in the fatty weakness, obesity and hypertension. Now what to do? What to do means what is the further investigation is like to do. আর কি কি এর ইনভেস্টিগেশন করে আমি একটা ডায়াগনোসিস রিচ করব যে কি হচ্ছে ওর, বলো এতদিন ক্লাস করার পরে এনিওয়ান বল না, ভুলভাল বল না, তাতেও তো সুবিধা। হ্যাঁ বল, আরে মুখ খোল রে ভাই, ভাই বাদে মুখ খুলতে হয়। What the further test you want to do? কি সিপেপটা মানে আগেই তো সিপেপটা চলে গেলি। Hypertension is there, obesity is there. This is much more relative and fatigue and weakness. That means the patients have to rule out in diabetes mellitus already developed or not, right? তাহলে আমি কি করব? ফাস্টিং সুগারই দেব, ফাস্টিং সুগারই দেব। No see now when it's C-peptide or fasting insulin level. If it is normal, if it is still it is normal, then we can't release the patients. Oh, তোমার কিছু হয়নি, weakness ভিটামিন দিয়ে দিচ্ছি, hypertension ওষুধ খাও চলে যাও। No, not at all, because patients having two already risk factor already have done. These patients may come in the hyperinsulinemia level, still he not developed insulin resistance. So we can change his lifestyle to reverse back to the normal. But if we release, it is happening. It is happening in OPDs. That is the fasting sugar is done. Suppose it is a normal, একটু ওজন কমান আর হাইপারটেনশন ওষুধ কার্ডিওলজি কাছ থেকে খেয়ে নিন। হয় বাবা, কেন? You didn't check in the lipid profile. Why? Obesity is such. Obesity means what? Obesity means his BMI is increased. That may be subcutaneous fat, that may be visceral fat, you don't know. And each and every patient can afford the MRI imaging to detect the whether patients having visceral fat and ectopic fats and subcutaneous fat. Already I described that how we can detect the visceral fat and ectopic fats, right? That's the MRI in imaging. You can't prescribe that. Nana sir বলেছিলেন, ডক্টর মুখার্জি বলেছিলেন MRI করতে হবে। No, not at all. It is the further study. Before that, you can assess the matter by seeing only the lipid profile. Lipid profile means triglyceride, LDL cholesterol, VLDL cholesterol, HDL cholesterol, all are important. Suppose these patients having triglyceride level is 170. 170. Obese patients, hypertension, sugar. Developed is a diabetes mellitus type 2, right? So such scenarios is happening. It is fatigue, diabetes, obese, hypertension, lipid profile altered, fasting sugar is high. So these things are, next question will come, what is the probable diagnosis you can achieve from this level? That is a metabolic syndrome, right? So what does it mean? Metabolic syndrome means that another two terms are very relevant nowadays after my lecture, that is insulin resistance syndrome. It is also called insulin resistance syndrome and syndrome X. Metabolic syndrome is two another name is that metabolic syndrome or syndrome and also insulin syndrome, right? Each and every point is important. So what does this mean, metabolic syndrome, and why it is so important and is currently knowledge must be there to predict early, to change your lifestyle, to prevent landed into the metabolic syndrome. If it is landing, the patients having sorts of complications of metabolic syndromes are variety of that. অনেক কিছু হতে পারে। metabolic syndrome যদি কখনো established করে যায়, I'm coming how we can establish the diagnosis of metabolic syndrome after knowing some 5 criteria is there. I'm coming, but still in the controversy in the 5 criteria are always there. I also like to explain this, but metabolic syndrome হওয়ার আগে পর্যন্ত আমাকে তার আগে আমাকে প্রিভেনশন করতে হবে। দ্যাট ইজ ইউর টেক হোম মেসেজ ফ্রম দিস ক্লাস, রাইট? হোয়াট ডাজ ইট মিন? টেক হোম মেসেজ তাহলে কি হচ্ছে? হোয়াট ডাজ ইট মিন? কি হয়েছে রে তোর? হোয়াট হ্যাপেন টু ইউ? Okay. So in this case, in this is happening is that hyperinsulinemia, insulin resistance, metabolic syndrome, then it will come into the cardiovascular problems, cancers, infertility, depressions, Alzheimer's disease, everything it can happen. Everything it can happen. So whenever you are dealing a patients of hyperinsulinemia, already you have to think, আমি যদি এখানে চেক করতে না পারি, that may patients into the accidents, CVA, strokes, everything can happen due to the metabolic syndrome. And when it is established, it is very much difficult to reverse back into the normal insulin level, because hyperinsulinemia আজকে আমার start হয়নি. It happens into the year of 25, 26. Then I developed hyperinsulinemia already, and then resistance already started. You can level of insulin resistance, you can reverse by the lifestyle changes. So I really practiced for the 40 patients per day. Now I reduce the 20 patients per day, strictly keeping my fees in high state. So that's why this lifestyle is important for our family also. If I die, then my family will be bigger. Like, so each and every in your family members is precious for us, and you also. So nowadays the young generations like you think that আজকে খেলে কি হবে, কালকে খেলেই বা কি হবে, এই তো কিছু হচ্ছে না, ঠিকই আছে। No, not at all. You are developing ultimately in the fatty liver disease. এখানে অনেক যদি স্ক্রিন করা হয়, কিছু না কিছু পেশেন্টের স্টুডেন্টের ক্ষেত্রে আমরা ফ্যাটি লিভার পেয়ে যাবো, পাবোই পাবো। Then fatty liver is a primary stage that is already you have resistance, insulin resistance, so that fatty liver grade আছে, grade 1, grade 2, you can reverse that. You can reverse by the your modification of life. HOMA-IR is done for the detection of the insulin resistance. You already know the fasting sugar in the mg per dl and fasting insulin micro unit per ml by divided by 405. It is more than 1.5, it is more than 1.5, then maintains into the insulin resistance. If it is within the 1.5 range, it's okay. Now it is okay for the resistance has not developed. But and that patients also hyperinsulinemia may happen. So 3 words in your total 5 days lecture is that hyperinsulinemia, insulin resistance, and the metabolic syndrome. বোঝা যাচ্ছে? So these things are your class notes must be there. Hyperinsulinemia, insulin resistance, and metabolic syndrome. বারবার বলবি. This is very much important for this one, and also for your family to understand. Suppose your family have some obese patients. Don't neglect. It's search for whether fasting insulin is high or C-peptide levels is high or not, and only seeing the only glucose level. অনেক ক্যাম্পে দেখবি করা হয়, ফ্রি ক্যাম্প হচ্ছে না, ফ্রি ক্যাম্পস কি করে তারা? I always suggest them, do ভাই যদি পারো, সমাজে যদি কিছু করতে পারো, so do for the insulin level or C-peptide level, then you are a good things you are doing, because insulin level is much more important than the glucose level. Remember that. You can't detect the insulin level. If you can't detect insulin level, patients having glucose যখন বাড়বে তখন insulin resistance already developed, and that's why patients may come in the like that is at 400 glucose, established diabetes mellitus. Now the 5 criteria to establish the metabolic syndrome are 4 highs and 1 lows. 3 high. What does it mean? Anyone? What are the criteria? Bolo. Central obesity. Wait. So number 1. As concerns my obesity, that is the waist circumference was about 86 of May, 2 months back before. So central obesity is the range is what should be the range? That means waist circumference. That means pharynx. ফিতে দিয়ে মাপবো, মাপবি সবাই আজকে গিয়ে umbilical region, ঠিক আছে? Must be. Good, smiling face, very good. So, waist circumference, what does it mean? Means the belly fat, means centimeter. In centimeter you can in inch also. If it is target must be less than 90 centimeter, possible in male, and less than 80 centimeter in female. ঠিক আছে, মেরাও মাপবে গিয়ে। If it is done, then okay. Highlight a formula for you. You can take easily in your hostel, that is the height. Height সবাই মাপতে পারবি। Now you can see only the in the কি বলে ফিতে নিয়ে মাপবি, ribbon to see your waist circumference, how much centimeter is that in the level of umbilicus. ফিতেটা নিয়ে এরকম level of umbilicus কত সেন্টিমিটার হচ্ছে। Now this waist circumference level into 2 একটা value, suppose x আমার 70 হলো, তাহলে 70 into 2 মানে আমার কত হলো? Suppose 70 centimeter, that is height in the meter. You can say that is the height. Centimeter is what? Height in centimeter, because it is centimeter. Its height taking. Suppose this is তুই নিলি মনে কর এটা 160, তাহলে কোনটা বড় হলো? হাইটটা বড় হলো। That means you are okay. That means you are still not in a phase of in a insulin resistance. But if the twice of waist circumference is more than the height, then you enter into hyperinsulinemia and insulin resistance. This is the back calculations. It is written in one journal, so I shared this, but not even so much emphasized. And that is also reliable, definitely. The waist circumference into 2 must be less than height. Must be less than your height in centimeter. Okay, you can see the centimeter normally 6y plus 77. 6y plus 70. Y means year. Normal in centimeter, it is a normal range of your height. Okay, anyway, it is not a BMI at all. It is not a BMI at all. It is not a BMI. Number 2, key. Yes. Value is fasting sugar, right? Fasting sugar less than 100 must be mg per dl. Or the patients taking some medications or with medications to decrease the sugar. সুগারের জন্য সে ওষুধ খায় বা তার less than 100 mg per dl fasting sugar আছে। এগুলো হচ্ছে ক্রাইটেরিয়া আসছে। নাম্বার 3, BP. You can say that is 130 and this is 85 or hypertensive state. So central obesity, circumference, diabetes type 2 and the hypertension, already 3 points gone. Number 4, HDL cholesterol, right? HDL cholesterol is a good cholesterol. Why it is good? Because after the releasing the VLDL from the liver, it transforms into the LDL, and HDL is present in the circulation. Then it takes the cholesterol from the LDL, and LDL cholesterol goes to the mainly the atherosclerosis to cause atherosclerosis. So it is a good cholesterol to collect the cholesterol and not to the peripheral tissue. So it's good. So its level 50 in male or less than 40 in female. Check করে নিবে একবার, and or any medication to increase this. এটা কি হলো? লেস হবে না, এটা বেশি হতে হবে, বোঝা গেল? HDL আমার যত বেশি হবে তত আমার জন্য ভালো, এলডিএল আমার যত কম হবে তত আমার জন্য ভালো, তাই না? সো এইচডিএল ইজ এ গুড কোলেস্টেরল, এ বাড়লে ভালো। কারণ কি? এ বাড়ছে মানে they are taking the cholesterol from the LDL and decrease the chances of atherosclerotic cardiovascular diseases, right? So this is number 4. What is it? Number 5. Triglyceride, very good, is a less than 150 normally mg per dl. So these things are 5 are the metabolic syndrome criteria. It is oftenly asked your exam, and it is theoretical also present. May come as a syndrome X also. If I go for the paper, then I can use the term the insulin resistant syndrome. So nowadays metabolic syndrome, the term has been changed into the insulin resistant syndrome because it defines all. Because hyperinsulinemia, after their insulin resistance, then only metabolic syndrome happens. Metabolic syndrome without insulin resistance never happens. So insulin resistance is the main culprit for the pathogenesis of all these things. So you are dealing, suppose in your family having 3 is altered, 3 of them, suppose fasting sugar 140, 180 by something 95. So 3 criteria among these 5, if it is present, then we establish the case the patient having metabolic syndrome. বোঝা গেল? এই 5টা ক্রাইটেরিয়ার মধ্যে if it is seen 3 criteria is fulfilled, then it is called only metabolic syndrome, right? Now there is some debates are there. Why in these 5 LDL cholesterol not taken? My questions is like that. You can ask also why LDL cholesterol is not taken, number 1. Number 2, why the high sensitivity CRP level not done, right? Because you already know the insulin resistance is important cause of metabolic syndrome, and insulin resistance, the cause of insulin resistance are hyperinsulinemia, stress and inflammations. So for the inflammations we can detect easily by seeing the high sensitivity CRP levels. So why it is not present? Probably it will come. It not come in till date, but it is debate is going on. Some papers, some journals, some evidence-based publications are going on like that. But still, one day you can find. Whenever I am telling in the 2024, you can send the 2025 or 26 that can be added easily. They can add. If you understand the pathophysiology and pathogenesis for the insulin resistance, then must be this included into this so that we can detect early. Right? So these things are very much important to detect the early. And if any patients having, you are suspecting patients having obese, must be these tests must be done to rule out the metabolic syndrome. If it is developed, then already patient have insulin resistance. You have to check lifestyle change, but you can't change the level of insulin resistance furthermore. Already developed, but you can stop or you can check the complications of the metabolic syndrome. What are those? Can you say that how insulin resistance cause hypertension? Anyone? Any ideas of that? Yes, please.
Normally, insulin stimulates lactic oxide for digestion, and with hyperinsulinemia, the activity of lactic oxide is reduced.
Yes.
And also, hyperinsulinemia stimulates RAS and there is vasoconstriction.
Okay. Okay, very good. If you write this in this way and you are thinking like way, it is a very good future in coming on. Because you have to do a clinician, so quality relation is smart. Those who are laughing and saying that, oh, no, not at all. This is the phase. This is the phase you have to learn something. Long time is very big subjects are there. You have to treat your own, not only your family members. Then you have to understand. If you don't understand in this level, into some fractions, then it is very much difficult to cope up with the correlations in the future. Future correlation korei amra khai. Kichu kori na. Just correlations and ideas and the knowledges. Bol kichu bolchis toi? You. Bol kichu bolchis? Stand up. Stand up. Ko jane. Ut. Oat, you, turn back. What happened? Why you are laughing? Why you are laughing? Come here. So these things are very much important. To hypertension, you're very good, very right thing you said. I add to some extent. What does what does it mean? Insulin is a growth hormone, right? Growth like hormone. It's not a GH, it's growth hormone, not like it's a growth hormone, means it can growth anything. So in the vessel, intimal level growth is happening due to insulin. So hyperinsulinemia causing the growth, that means vessels are there, internally growth is happening, so it is a squeezing. The diameter is hypertension. Number one. Number two, it activates the adrenal level, adrenal cortex, adrenal levels, and then what happens? Basically adrenal, aldosterone. What does the aldosterone done? Aldosterone is causing the sodium water retention and causing the hypertension. And nitric oxide already he explains nicely, because insulin has role some nitric oxide synthase actions, and if it is insulin resistance, then that happens is hypertension. Now, the complications of the metabolic syndromes are mostly cardiovascular thrombotic mechanism. Now thrombosis এলো কোত্থেকে স্যার? থ্রোম্বোসিসের কথা বলছেন, is a প্রোথ্রম্বোটিক স্টেজ। কেন? নাও আবার ফ্যাট সেলে আমাকে চলে যেতে হবে। ফ্যাট সেল মিন্স অ্যাডিপোজ টিস্যু, টাইম আছে? অ্যাডিপোজ টিস্যু। So adipose tissue is nowadays is called the endocrine gland or endocrine organ rather, because it releases the hormone. কি হরমোন বের করে? লেপটিন বের করে, ঠিক। একটা গ্রস টার্ম আছে, বল। Adipokinins, right? Adipokinins as a whole, it is called adipokinins. From the adipocytes, different adipokines are released. Adipokines, like that, adipokines are released. There is adiponectin, leptin, resistin, and also plasminogen activator 1. প্লাজমিনোজেন অ্যাক্টিভেটর ইনহিবিটর 1, এটা পড়িছিলাম, মনে আছে? হ্যাঁ, ডিউরিং দ্য fibrinolysis, ভুলে গেছিস? So these things are released from the fat cells, and this is the culprit for the prothrombotic phenomena. What does it mean? Thrombosis of many small arteries, that is the coronary vessels, may thrombotic, and that may come into the stroke. So stroke, cardiovascular accident, dementia, Alzheimer's disease is important. Alzheimer's disease is very much common nowadays in elder ages. Alzheimer's disease, have you heard the term? Yes, Alzheimer's disease also is yes, বলে অনেক, right, very good, এটা অনেকে বলে plantaris. It's not established so much, but it is written in some journals also. It is diabetic type 3. So this happens cardiovascular accident, CVA, and then also cardiovascular accident, stroke, then polycystic ovarian disease syndrome, polycystic ovarian syndrome, PCOS. What does it mean? In the female patients having some cystic definitions are there, cysts are going on, then cysts are happening due to the insulin resistance. What does this mean? I am not going detail at all, because you have to learn about the estradiol, estrogen, esterase, everything is coming. I am not going details, you feel bored. So polycystic ovarian disease is the complications of this metabolic syndrome, and believe me, in the OPDs, many female patients, obese female patients may come like infertility problems like that, and so that many gynecologists prescribe that metformin. Metformin is a anti-diabetic drug, but it helps to reduce the insulin resistance, because the fundamental ideas of insulin resistance already in the mind in that gynecologist, that this happens due to the insulin resistance. Number one. In case of female. In case of male, that is the erectile dysfunctions. Erectile dysfunctions may cause infertility in male. How it is possible? Any ideas? How it is possible for metabolic syndrome? তাহলে যারা ভাবছিস যে মেটাবলিক সিনড্রোম মদ খাবো সিগারেট খাবো হলে হবে যা হবে দেখা যাবে, the males may suffer from the erectile dysfunctions, right? So why it is happens? Same thing, insulin, nitric oxide. Nitric oxide causing the vasodilatations, and for the erections of the male genitalia, it's causing the mainly vasodilatations, congestions of venous, and so that if nitric oxide not released, then that causing the erectile dysfunctions. So very beautiful explanations are there. So metabolic syndrome not only for your cardiovascular diseases or cardiovascular arrest or any parts of strokes, etc. In case of female may accompany with the polycystic ovarian disease, and I suggest if any obese students also at least 1 USG per year you have to done, and always take the vaccinations of human papilloma virus, that is called cervical CA. কে কে নিয়েছিস হাত তোল, female? Nobody? Just go to your parents and ask and meet any gynecologist or any pediatricians. Then you have to done 2 doses of 2 doses হবে না, there are 3 doses of HPV vaccinations to prevent the cervical cancers. So for the female patients or female any patients, any female 9 to 14 years, 2 doses of HPV vaccines is must. Remember that. Female students, make it clear, you have to invest to take 3 doses, because after the 14 years, 3 doses is must. Nowadays is very high grade vaccines are available around 10,000. I am not suggesting that, but you can around the 4,000. You have to bear the 3 doses, that means 12,000. You have to bear to protect the more than 95% protections of your cervical CA. And nowadays, the cervical CA is happening is very rapidly. So remember this. It was my duty to send a message related to the PCOS. So that patients having some cervical CA, having some polycystic ovarian diseases. So any obese students, you can go through the annually the USG from a gynecologist to check, and also diabetes and lipid profile also must be checked, and HPV vaccines must be taken. So anyway, so this is the complications of the metabolic syndrome. Gist, Bal, what are the complications of metabolic syndrome? Tell me. Diabetes mellitus is not a complication of metabolic syndrome. It is the metabolic syndrome, is a part of the metabolic syndrome. It has already happened, so that we are telling them. Complications. Obesity is already there. The central obesity is there. Hypertension is already there. I am telling the complications, not the criteria for the metabolic syndrome. So what are the complications? Complications is cardiovascular diseases, heart attacks, strokes, ischemic heart disease, cancer. Cancer, how it is possible? Suppose I am taking the fatty liver. Fatty liver means deposition of fat as causing the fibrosis, then the cirrhosis, then the carcinoma of the liver. So it can predispose. Similarly, metabolic syndrome and the colon cancer is very much dependent, very much dependent. So obese patients having metabolic syndrome may chance or the colonic CA, that is colon cancer. So cancer, then PCOS, polycystic ovarian syndrome in case of female, and erectile dysfunctions in case of male. Then again depression, anxiety, Alzheimer's disease. That means neural toxicity for the hyperinsulinemia. Hyperinsulinemia is a main culprit, then insulin resistance, then metabolic syndrome, then complications. In this scenario, the take-home message from this class is hyperinsulinemia, insulin resistance, metabolic syndrome, complications, right? So last is a obstructive sleep apnea. Patients may come, Doctor, আমার রাতে ঘুম হয় না, বারবার নাক ডাকি আর ঘুমায়, বা তার ওয়াইফ বলছে, বা তার মা বলছে, বাবা বলছে যে রাতে ঘুমাতে পারে না, এতটাই সে নাক ডাকে। So obstructive sleep apnea, you have to, polysomnography is a test for detect the obstructive sleep apnea. If it is diagnosed, it is mostly obese related and metabolic syndrome complication. So, metabolic syndrome complications may come in your exam also. Metabolic syndrome is come in exam also. What is metabolic syndrome or syndrome X, or may come as a insulin resistance syndrome, right? So you have to write everything, and the levels are very important. And today your home task is that whether you are all is resistance sensitive or not, by seeing only the waist circumference and the height. If your twice of waist circumference is key more than the height, you are in a problem. If it is less, then now it is okay. So change your lifestyle, change your food diets. Till 40 years is okay, but remember this metabolic syndrome depends upon some risk factor. One of the important factors is age, then race, ethnicity, sex, female are more important. Then the risk factors like the cyst, like the cervical CA, erectile dysfunctions, all are the risk factor. Risk factor means that risk factor may predispose or landed into the metabolic syndrome proper. তাহলে আমি যদি কোনো পেশেন্টকে পলিসিস্টিক ওভারিয়ান ডিজিজ আগে ডায়াগনোস করতে পারি হ্যাভিং উইদাউট এনি ডায়াবেটিস, তো সেই পেশেন্টের পরবর্তীকালে ডায়াবেটিস হবে না, রাইট? So you already termed that the gestational diabetes, probably gestational diabetes means during the pregnancy period, mother or going to be mother, a female mother can develop diabetes mellitus. What does it mean? It means insulin resistance. So demand is high, hyperinsulinemia happening, and insulin resistance is transitory. This is called transitory insulin resistance because after the delivery, insulin levels will come down and insulin resistance can be corrected and diabetes will be corrected. So that is also important for your knowledge. So take home message from this class for 5 to 3 days. I done this. Go through the whatever I missed. There is a glucose tolerance test and diabetes mellitus, complications, types. It's everything is in this chapter. Remember 3 to 4 things. That is a chronic low-grade inflammation, insulin resistance, fat cell hypertrophy, dangerous. Subcutaneous fat is much more better than the visceral and ectopic fats. If you are dealing with the visceral fat, that means you are going to be insulin resistance by that pathogenesis already I described by the release of some cytokines like TNF alpha and interleukin 6. And these go to the insulin resistance to the other organs like liver, muscles and pancreatic alpha cells. So insulin resistance whenever you are developed, then only you can land it into the metabolic syndrome by these 5 criteria are there. So waist circumference, central obesity, in your family also, if you are seeing that your mother, father or your maternal uncles or auntie is too much obese, always you suspect and see the whether his waist circumference is and do a routine lipid profile and a fasting sugar at least. So you can check the BP itself. Say you know আমরা বলি না যে BP তো তোকে দেখতেই হবে। যে স্টুডেন্ট বিপি দেখতে পারে না, I think he or she should not pass in the first year of professional MBBS. হয়েছে এটা আগের বছর বিপি হচ্ছে উল্টো, বিপি ভাবতে পারে না, you don't know about the oscillatory gap. These things are important to you in your society. So I can't release such a student without any knowledge. এটা আমি করতে পারবো না ভাই। So to some extent you some basic knowledge to pass the exam, and it's very easy. I already explained in the 10 minutes in the previous class. That is কি বলেছিলাম অল্প অল্প করে কনসেন্ট্রেশন নিয়ে পড়তে হয়, কারো দিকে তাকানো যাবে না। Read properly each and every classes and take home messages from each and every classes and apply it in your paper. That's the important point. Like, so any questions after this? This is a endocrine pancreas. It is amylin already described insulin, C peptides, insulin hyperinsulinemia, insulin resistance, metabolic syndrome, complications, everything, right? So go through your good books. If not possible, go through my lectures and listen. এই লেকচারগুলো তো ভিডিওতেও হয়, খুলে তো দেখতে পারিস তো। That is also may be helpful for you. So it's much helpful. So remember, subcutaneous fat is less dangerous than the visceral fat. Hyperinsulinemia is most dangerous than the glucose level high. And you have to detect hyperinsulinemia before the diagnosis of diabetes mellitus. But whenever you are detecting the diabetes mellitus, already the patients having insulin resistance developed. If insulin resistance develop, then the patients may come after 15 years, 10 years, that is the metabolic syndrome. So I am in the phase of pre-diabetic phase. If I not restrict my lifestyle in the feeding habits, like the carbonates and some junk foods, etc., that creates a carbohydrates, lots of carbohydrates. Much more carbohydrate means much more spike of insulin in regular interval. So frequent feeding is must be avoided. These things must be avoided. If in your family, not for you, in your family, they can take as an intermittent fasting. This is the new concept is that if you 12 to 16 hour fasting, and they take as a breakfast and lunch together, and then again in a life of beggar's meal in the dinner, then again you are taking the lunch and breakfast together, right? In that case, you decrease the low carbohydrate. Definitely, hyperinsulin level will low down, and chances of insulin resistance will be less. Chances of metabolic syndrome will be less. Metabolic syndrome complication will be less. Thank you very much. This has been my class. Thank you.
কিরকম অবস্থা দেখি, এই যে কার্ভ, এই কার্ভের কি নাম, এটার কি নাম, এই চার্টের কি নাম? হ্যাঁ হ্যাঁ, সিম্পল মাসেল কার্ভ। হ্যাঁ, সিম্পল মাসেল কার্ভ বা সিম্পল মাসেল টুইচ, এর ডেফিনিশন কত রোল তোমার? হ্যাঁ, এটা ডেফিনিশন কি সিম্পল মাসেল কার্ভের? কি ডেফিনিশন জানো না? হ্যাঁ, তাহলে এই ডেফিনেশনটা পড়তে হবে সিম্পল মাসেল কার্ভ। হ্যাঁ হ্যাঁ, তারপরে কুইক কন্ট্রাকশন followed by brief within brief relaxation in response to single induction shock, single action potential. বোঝা গেল? হ্যাঁ, এটা ম্যাক্সিমাল বলা যাচ্ছে না, কারণ কিছু লেখা নেই, মানে এটা থ্রেশহোল্ডের বেশি আছে সেটা বলা যায়, সাব ম্যাক্সিমাল এরকমভাবে বলা যেতে পারে। লেখা নেই সেখানে। তাহলে এইগুলো তোমাদের সমস্ত কিছু জানতে হবে। এখন তোমার এই যে আগের দিন আমরা বলা হয়েছিল যে এগুলো ডিফারেন্ট পিরিয়ড গ্যাপগুলো, এই যে আজকের আরও চার্ট আছে, সব একদিনে সব শেষ হবে না। এই যে এখানে দেখতে পাচ্ছ, হ্যাঁ এই দেখো, এই যে এই চার্ট, এই চার্টের কি নাম? এই যে এটা হচ্ছে কি লেখা আছে এখানে, এফেক্ট অফ টেম্পারেচার। দেখো, এফেক্ট অফ টেম্পারেচার, বুঝতে পারছো? হ্যাঁ, এফেক্ট অফ টেম্পারেচার অন নার্ভ মাসেল প্রিপারেশন, নার্ভ মাসেল প্রিপারেশন। এখানে এই দুটোই হচ্ছে সিম্পল মাসেল কার্ভ, ডিফারেন্ট টেম্পারেচারে আছে। একটা যে নর্মাল টেম্পারেচার, একটা 40 ডিগ্রি সেন্টিগ্রেড। তাহলে এক্ষেত্রে কি চেঞ্জ পাওয়া যাচ্ছে? 40 ডিগ্রি সেন্টিগ্রেডে কি আছে? নর্মালের সঙ্গে 40 ডিগ্রি সেন্টিগ্রেড টেম্পারেচারে সেটা, এবং এটা কীভাবে করা হয়, যে ফ্লক্সালাইন দেওয়া হয়। ফ্লক্সালাইন 40 ডিগ্রি সেন্টিগ্রেডে ফ্লক্সালাইন দেওয়া হয়। লুকাস চেম্বার হলে ভালো হয়, না হলে থাকলে এমনি যে মাসেল, আমরা যে আমাদের যে মাসেল বোর্ড, তার উপরেও সেটা দিয়ে আমরা সাধারণত করতাম, তুলোতে ভিজিয়ে সেটা দিতে হয়। ফ্লক্সালাইন 0.6% টেম্পারেচারটা সেরকম আগে দেখে নিতে হয়, সেটা সেখানে দিতে হয়। খানিকক্ষণ বাদে প্রথমে আগে নর্মাল কার্ভ নেওয়া হয়, তারপরে এই টেম্পারেচার 40 ডিগ্রি সেন্টিগ্রেড টেম্পারেচার দিয়ে একটু পরেই আবার একটা রেকর্ডিং করতে হয়। করলে পরে এখানে চেঞ্জ পাওয়া যাচ্ছে। তাহলে এখানে কী কী কনস্ট্যান্ট থাকবে? যে সেকেন্ডারি আর প্রাইমারি ইন্ডাকশন কয়েলের মধ্যে যে ডিস্টেন্সটা আগে ছিল সেটাই বলবৎ থাকবে। বোঝা গেল তো? হয় তুমি ম্যাক্সিমাল স্টিমুলাস নেবে, আর যদি না নাও তা সেক্ষেত্রে তোমার ইন্টেন্সিটি, মানে তোমার স্টিমুলাস স্ট্রেংথটা একই থাকবে, শুধু টেম্পারেচারে শুধু চেঞ্জ হবে, একই পয়েন্ট অফ স্টিমুলেশন থাকবে। বললে পরে দেখা যাচ্ছে কি নর্মালের থেকে এর তুলনায় হাইট অফ দি কার্ভ বেড়েছে। হাইট অফ দি কার্ভ, এটা আইসোটনিক কন্ট্রাকশন। তাহলে হাইট অফ দি কার্ভ, তার মানে সেক্ষেত্রে লোডটাও একই রয়েছে, যা লোড আমি দিয়েছি সেই লোডটাই রয়েছে। তাহলে সেক্ষেত্রে এটা হাইট অফ কন্ট্রাকশন যখন বেড়েছে, তোমার নিশ্চয়ই সেখানে বেশি ফোর্স জেনারেটেড হয়েছে। তাহলে হলো কী করে? এই যে ফোর্স জেনারেশন হয়, মাসেল কন্ট্রাকশন, সেটা কী কারণে হয়? মাসেল কন্ট্রাকশন যে ফোর্স জেনারেশন হয় সেটা কী কারণে হয়? তার মানে সেটা নির্ভর করে কার উপরে? নাম্বার অফ অ্যাক্টিন মায়োসিন, যে হচ্ছে ব্রিজটা যেটা হচ্ছে সেই জন্য হচ্ছে। মায়োসিন হেড আর অ্যাক্টিন যে যুক্ত হচ্ছে সেটা সংখ্যার উপরে নির্ভর করছে, সংখ্যার উপর নির্ভর করছে। এখন সেখানে নিশ্চয়ই সেখানে কোনো চেঞ্জ হয়েছে যার ফলে এরকম হাইটটা বেশি হয়ে রয়েছে। মাসেল কন্ট্রাকশনটা অ্যাক্টিভ প্রসেস এবং এটিপিএস অ্যাক্টিভিটি, টেম্পারেচার যদি একটু বাড়ে তাহলে পরে সেইখানে এটিপিএস অ্যাক্টিভিটি বেড়ে যায়। এটাই প্রধান কারণ। হ্যাঁ, সেই কারণেই হয়তো এখানে হয়েছে। ক্যালসিয়াম আয়নের অ্যাভেলেবিলিটি বা অন্যান্য কোনো ফিচারও থাকতে পারে, হাইটটা বেড়েছে। এবং দেখা যাচ্ছে কন্ট্রাকশন পিরিয়ডটা সেখানে শর্ট হয়ে গেছে, কন্ট্রাকশন পিরিয়ড। কাজেই এক্ষেত্রে নর্মাল এখান থেকে শুরু ছিল, এটা আগে চলে এসছে। এটা তো পয়েন্ট অফ স্টিমুলাস সেম রয়েছে, তারপরে কন্ট্রাকশন সেখানে কন্ট্রাকশন পিরিয়ডটা শর্ট হয়ে গেছে, আর্লি কন্ট্রাকশন হচ্ছে, রিল্যাক্সেশন পিরিয়ডটা শর্ট হয়ে আসছে। কারণ এটা রিল্যাক্সেশন, এটা হচ্ছে এন্ড অফ রিল্যাক্সেশন, তার আগে এটা পড়ে যাচ্ছে, সেটা তার আগে এটা পড়ে যাচ্ছে, এই চেঞ্জ হচ্ছে। মেজারগুলো কী করা যাবে, নিচে টাইম ট্রেসিং দেওয়া আছে, t=0.01 সেকেন্ড। এখানে দেখো কি লিখেছে, দেখো তো এখানে দেখো চেঞ্জের মধ্যে কি লিখেছে, টেম্পারেচারে কি চেঞ্জ এখানে লিখেছে। হ্যাঁ হ্যাঁ, ওই হেডিংটা কি দিয়েছে, কি ওয়ার্ম হ্যাঁ রিঙ্গার সলিউশন, ওয়ার্ম রিঙ্গার সলিউশন। বুঝতে পেরেছো, রিঙ্গারের দ্রবণ। সেখানে এখানে নর্মাল স্যালাইন সাধারণত দেওয়া হয়, তার সঙ্গে সঙ্গে অন্যান্য উপাদানও এখানে মেশানো উচিত। বুঝতে পারছো, এবং তার হিসাবও আছে কীভাবে সেটা তৈরি করতে হয়। পটাশিয়াম ক্লোরাইড, ক্যালসিয়াম ক্লোরাইড, সোডিয়াম বাইকার্বনেট, হ্যাঁ, এগুলো জল ছাড়া, জল এবং সোডিয়াম ক্লোরাইড ছাড়া সেগুলো মেশানো হয়, করে নির্দিষ্ট অনুপাতে মিশিয়ে তবে রিঙ্গার্সের দ্রবণ তৈরি করা হয়। এটা ফ্রগ রিঙ্গার্স। সেখানে গরম পড়লে কি চেঞ্জ হয়, এবার হ্যাঁ সুন্দরভাবে বলো, এখানে তোমার গলা খুব সুন্দর, হ্যাঁ জোরে বলো, হ্যাঁ হ্যাঁ জোরে বলো, হ্যাঁ
Height of the curve increases,
হ্যাঁ
duration of all the three phases, T, CR, RP decreases, speed of contraction and relaxation increases.
তো কারণ কি দিয়েছে, কিছু দিয়েছে।
Mechanism হচ্ছে increase excitability by hastening various metabolic process of muscles, synaptic delay decreases the viscosity of muscle.
আরেকবার জোরে করে শুনে নাও কি লেখা আছে বইয়ে লেখা আছে কি। হ্যাঁ,
increases the excitability by hastening various metabolic process of
হ্যাঁ
muscle,
হ্যাঁ
synaptic delay decreases the viscosity of muscle.
হ্যাঁ, তার মানে এখানে বলছে যে মাসেলের অ্যাক্টিভিটি বাড়বার জন্য এনজাইমের অ্যাক্টিভিটি বাড়বে, সোডিয়াম পটাশিয়াম এটিপিএস অ্যাক্টিভিটি বাড়বে। তার সঙ্গে সঙ্গে ওই এখানে ক্যালসিয়ামটাকে যে রিটার্ন ব্যাক করছে, হ্যাঁ, সেটা ফেসিলিটেটেড হবে, যার ফলে রিল্যাক্সেশনটা শর্টেন হয়ে যাবে। সেটা শর্টেন হয়ে যাবে। আর বলছে যে সাইনাপটিক, এটা সাইনাপস বলতে এখানে নিউরোমাস্কুলার জাংশনটাই এখানে বুঝিয়েছে, সেখানে কিছু ফেসিলিটেশন হবে। হ্যাঁ, আর তারপর কি বলছে, ভিসকোসিটি কমে যাবে, ভিসকোসিটি কমে যাবে। ভিসকোসিটি কোথায় কমবে, কোথায় ভিসকোসিটি কমবে, এটা হচ্ছে হ্যাঁ সার্কোপ্লাজমে কমবে, সার্কোপ্লাজম হ্যাঁ, সার্কোপ্লাজম হচ্ছে সাইটোসল অফ দি মাসেল, হ্যাঁ মাসেল সেলসকে বলে হচ্ছে সার্কোপ্লাজম। ভিসকোসিটি কমে গেলে পরে ইন্টারডিজিটেশনটা ফেসিলিটেটেড হবে, এই আর সব মিলিয়ে এই এফেক্টটা একটা পাওয়া যাবে। এটা যে এফেক্ট অফ টেম্পারেচার। আর এখানে যেটা আছে এই যে এটা হচ্ছে তাপমাত্রা হচ্ছে 40 ডিগ্রি সেন্টিগ্রেড, কিন্তু এর বেশি করা হবে না। 45 ডিগ্রি সেন্টিগ্রেড হয়ে পরে মাসেল কোয়াগুলেশন হয়ে যাবে, হ্যাঁ, ডিনেচার্ড হয়ে গেলে পরে সেক্ষেত্রে রিজিডিটি তৈরি হবে, অ্যাক্টিন মায়োসিন এরকমভাবে ওটা যে ডিম সিদ্ধের মতন হয়ে যাবে, তখন সেটা কোনো কাজে লাগবে না সেই টিস্যুটা। সেই জন্য সেটা হিট রাইগর বলছে, হ্যাঁ, সেই জন্য টেম্পারেচারটা এর মধ্যেই রাখতে হবে। বুঝতে পারছো। আর এখানে রয়েছে যে নর্মাল টেম্পারেচার আর 10 ডিগ্রি সেন্টিগ্রেড। নর্মাল টেম্পারেচার প্রথমে যে কার্ভ, এই দুটোই হচ্ছে সিম্পল মাসেল কার্ভ। তাহলে এখানে কি চেঞ্জ পাওয়া যাচ্ছে, এখানে দেখো, এখানে 10 ডিগ্রি সেন্টিগ্রেডে এর তুলনায় লেটেন্ট পিরিয়ডের বৃদ্ধি হয়েছে, আর হাইট অফ কন্ট্রাকশন কমে গেছে, রিল্যাক্সেশনটা প্রলংড হয়েছে। দেখো এখানে কি লিখেছে, জোরে 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 পড়বে একটু, হ্যাঁ।
Height of the curve decreases, duration of all the three phases increases, speed of contraction and relaxation decreases.
হ্যাঁ, তাই কারণ কিছু দিয়েছে এখানে দেয়নি, তার মানে ওখানে যেই কারণে হয়েছিল তার বিপরীত কারণে হচ্ছে, মানে এনজাইম অ্যাক্টিভিটি সেখানে কমে যাচ্ছে, বুঝতে পেরেছো? 10 ডিগ্রি সেন্টিগ্রেড ওটা দিলে পরে এটার সঙ্গে এরকমভাবে সেটা যাচ্ছে, লেটেন্ট পিরিয়ডটা বেড়ে গেছে, তার মানে নিশ্চয়ই ওখানে নার্ভ কন্ডাকশন ভেলোসিটির কোনো চেঞ্জ হয়েছে, বা নিউরোমাস্কুলার জাংশনে কোনো রকম ট্রান্সমিশনে কোনো রকম সেখানে হচ্ছে সামান্য বিঘ্ন হচ্ছে তাপমাত্রা কমাতে, এগুলো। আর মায়োসিন এটিপিএস অ্যাক্টিভিটি যদি কমে যায় তাহলে পরে কী হবে, সেখানে ক্রস ব্রিজ ফর্মেশনে ব্যাঘাত হচ্ছে, স্লো হয়ে যাবে, ফাস্ট স্লো মাসেল আছে না সেরকম, তার মানে কি যে সেখানে স্পিডটা এর এনজাইম অ্যাক্টিভিটির উপর নির্ভর করে। বুঝতে পারছো জিনিসটা? এগুলো না বোঝার কিছু নেই এখানে। হ্যাঁ হ্যাঁ, ইন্টারসেলুলার এইভাবে বসতে নেই, এইভাবে ওইটা ওই কবি টবি যারা আছে ছবি দেয় এরকম, এইখানে এইসব ব্যাপার নেই। হ্যাঁ, তোমার কত রোল তোমার? হ্যাঁ হ্যাঁ, ক্যালসিয়াম আর কনসেন্ট্রেশন রেস্টিং কন্ডিশনে স্কেটার মাসেলের ভিতরে কত থাকে? হ্যাঁ, calcium ion concentration in the cytosol during rest in skeletal muscle কত থাকে ক্যালসিয়াম আয়ন কনসেন্ট্রেশন? বুঝতে পেরেছ? হ্যাঁ, মানে সার্কোপ্লাজমে রেস্টিং কন্ডিশনে ক্যালসিয়াম আয়ন কনসেন্ট্রেশন কত থাকে জানো না? এটা না জানলেও কোনো লজ্জিত হওয়ার কিছু নেই, অনেকে অনেক অপরাধ করে লজ্জিত হচ্ছে না দেখছি, হ্যাঁ খুশি মনেই আছে, কাজে এটা ধর কোনো অপরাধ নয়, তুমি একটু দেখে নেবে এগুলো ডেটা, বুঝতে পেরেছো? খুব সহজ জিনিস ফিজিওলজি, কালকে উঠেই যাবে, হয়তো সাবজেক্টে তো উঠেই যাবে, বলবে ইউনিভার্সিটি জানার দরকার নেই, হায়ার সেকেন্ডারিতে সাফিসিয়েন্ট শিখে এসছে, এখন এটা কম্পিউটারের যুগ, ডিজিটাল যুগ, আপনারা কিছু পড়াচ্ছেন হাবি যাবি, দরকার নেই। হ্যাঁ, তো বলতে পারে, বলা যায় না, তো আমাদের বলেছি আপনাদের হ্যাঁ হ্যাঁ, তারপর আপনার বিদায় নিন, সাবজেক্ট দরকার নেই, এটা হতে পারে, অনেক কিছুই হয় দেখছি, আমি যেটা ভাবি সেটা কিছুদিন বাদে কার্যকর হয় অনেক সময়, সেই দিকে এগুচ্ছে, বুঝতে পারছো তো? ওটা মনে রাখবে, মানে 10⁻⁷ অথবা তার মোল পার লিটার, মোল পার লিটার কি এটা? হ্যাঁ, ফুল সেট এটাতে আছে, এটা আছে, যে কোনো একটা আমাকে দিন, কোনটা? হ্যাঁ হ্যাঁ, না না ওই একটা দিন আপনার কাছে থাক, এটা আরে ওরা দেখবে কি, ওরা খুব ভালো ছেলে সব, ওরা কি দেখবে। তাহলে এফেক্ট অফ টেম্পারেচার এটা হলো, টেম্পারেচার সিম্পল মাসেল কার্ভের মতনই সেই অ্যারেঞ্জমেন্ট করতে হবে, এরকম অ্যারেঞ্জমেন্ট করতে হবে, করে নিয়ে তারপর তোমার এই যে সিম্পল মাসেল অ্যারেঞ্জমেন্ট, এটা প্রথম দিন তোমাদের ছবি আঁকা ছিল না, তারপরে এটা সময় কম আছে, এই জন্য তোমাদের এটা একটু দেখে নাও। আবার যারা আজকে প্রথম আসছে, এরকম আছে না নবাগত কেউ আছে না আজকে? হ্যাঁ আছে কেউ নবাগত, যারা যে কোনোদিন এই ক্লাস করেনি, হাত তোলো হাত তোলো হাত তোলো, হ্যাঁ কেউ আছে না তোমাদের মধ্যে নবাগত, একদম কোনোদিন অ্যাম্ফিবিয়ান ক্লাসে আসনি, এরকম কেউ আছে? হাত তোলো হাত তোলো, কেউ আছে না? নেই? তাহলে প্রথম দিন এটা আলোচনা করা যায়নি, দ্বিতীয় দিন অনুপস্থিতির সংখ্যা একটু বেশি ছিল। হ্যাঁ, তা এটা একটু দেখে নাও, তোমার হচ্ছে যে এই যে দুটো তার গিয়েছে, এটা হচ্ছে স্টিমুলেটার, কাকে স্টিমুলেট করছে? এখানে দেখা যাচ্ছে এটা নার্ভ দেখা যাচ্ছে, এই নার্ভটা হচ্ছে সায়াটিক নার্ভ, কোন প্রাণীর? এটা ফ্রগের, বুঝতে পেরেছো? ফ্রগের এটা সায়াটিক নার্ভকে স্টিমুলেশন করা হচ্ছে। স্টিমুলেশনের উৎপত্তি কোথায় হয়েছে? এসসি লেখা আছে, হ্যাঁ, সে মানে সেকেন্ডারি ইন্ডাকশন কয়েল, এখান থেকে এটা গিয়েছে, বুঝতে পেরেছো? আর এইখানে লেখা আছে প্রাইমারি ইন্ডাকশন কয়েল, হ্যাঁ, মুখ্য কুণ্ডলিতে প্রাইমারি ইন্ডাকশন কয়েল, এটাতে ডাইরেক্ট কারেন্ট দেওয়া হচ্ছে, 2 to 8 ভোল্ট, 5-6 ভোল্ট এরকম দেওয়া হয়, ব্যাটারি থেকে দেওয়া যেতে পারে, অথবা স্টেপ ডাউন ট্রান্সফরমার থেকে দেওয়া যেতে পারে। দিলে পরে সেক্ষেত্রে মেক ব্রেক যখন হবে, তখন এখানে কারেন্টের উৎপত্তি হয়, বুঝতে পেরেছো? এটা হচ্ছে ফ্যারাডিক কারেন্ট বলে, শর্ট লাস্টিং কিন্তু হাই ভোল্টেজ, এরকম কারেন্ট তৈরি হয়, ফ্যারাডিক কারেন্ট বা ইনডিউসড কারেন্ট, আবেশী তড়িৎ, বুঝতে পেরেছো? তড়িতাবেশ হয়। হ্যাঁ, এই যে এখানে যখন এটা হচ্ছে প্রাইমারি ইন্ডাকশন কয়েল, এর পাক সংখ্যা কম থাকে, থিক ওয়্যার থাকে, পাক সংখ্যা কম, আর এখানে ছবিতে দেখানো হয়নি, এর ভিতরে কাঁচা লোহার তার থাকে, তারপরে যেই এখানে বিদ্যুৎ যাবে, তখন এখানে একটা শক্তিশালী তড়িৎচুম্বক তৈরি হবে। হ্যাঁ, সেই তড়িৎচুম্বকের যে এইগুলো বলরেখা, বলরেখা সব জায়গায় ছড়িয়ে পড়বে, তার মধ্যেই এটা রয়েছে, প্যারালালি রয়েছে, ম্যাক্সিমাম হবে কোনো নির্দিষ্ট ডিস্টেন্সে। তারপর এখানে যে, এবং এর ভিতরে যদি এই যে বলরেখা যেগুলো যাচ্ছে তড়িৎ ক্ষেত্রে, যদি এখানে যদি বিদ্যুৎ ক্ষেত্রে যদি এখানে যদি ওর যদি বলরেখার যদি পরিবর্তন হয়, হ্রাস বৃদ্ধি যদি হয়, অথবা আবির্ভাব বিলোপ যখন হবে, তখন এই সেকেন্ডারি ইন্ডাকশন কয়েলে তোমার তড়িতাবেশ হবে, এবং সেটা যে ফ্যারাডিক কারেন্ট। এবং এখানে মেক অ্যান্ড ব্রেক করা হয়, সার্কিটটা এরকমভাবে নেওয়া হয়। এই যে পাওয়ার সোর্স থেকে গিয়েছে, এখানে কোথায় গিয়েছে, এটা হচ্ছে কন্ট্যাক্ট ব্লক। ওই যে ওখানে দেখতে পাচ্ছ কন্ট্যাক্ট ব্লক আছে, কন্ট্যাক্ট ব্লক আছে, এবং সেখান থেকে একটা প্রজেকশন বেরোয়, সেটা কন্ট্যাক্ট ফয়েল বলে, কন্ট্যাক্ট ফয়েল বলে, অথবা কন্ট্যাক্ট স্প্রিং এরকম বলা হয়। আর এখানে দেখতে পাচ্ছ যে এই যে এখান থেকে যে উল্লম্ব আছে, লৌহদণ্ড রয়েছে, যেটা স্টিলের যে দণ্ড রয়েছে, এটাকে বলে স্পিন্ডিল অথবা শ্যাফট। এবং এর নিম্নে এখানে ডুয়াল কন্ট্যাক্ট আর্ম অথবা স্ট্রাইকার রয়েছে, বুঝছো, দ্বিধা বিভক্ত এরকম স্ট্রাইকার রয়েছে, স্ট্রাইকার। সে যখন একে টাচ করে চলে যাবে, তখনই সেখানে তার মানে কারেন্টটা মেক এবং ব্রেক হচ্ছে। ব্রেক কারেন্টটা স্ট্রঙ্গার দ্যান দি মেক কারেন্ট, কারণ রেট অফ চেঞ্জ অফ ফ্লাক্স ডিউরিং ব্রেক ইজ কুইকার, রেটটা বেশি, সেজন্য এখানে বেশি হবে। কিন্তু সাধারণ ক্ষেত্রে আমাদের এখানে মেক কারেন্ট দিয়ে এটা করা হয়। মেক কারেন্ট, এই যে কার্ভগুলো হচ্ছে মেক কারেন্ট দিয়ে করা হয় আমাদের ক্ষেত্রে, এখানে বেশিরভাগ ক্ষেত্রে। কেন করা হয়, যে তারপরে এটা করা সহজ। আর মেক কারেন্টের অব্যবহিত পরেই আসছে ব্রেক কারেন্ট, তার মানে সেই অব্যবহিত পরে যদি আসে, তারপরে সেখানে সেকেন্ড স্টিমুলাসটা এফেক্টিভ হচ্ছে না, তার কারণ সেটা প্রথম স্টিমুলাসের যে অ্যাকশন পোটেনশিয়াল তার অ্যাবসোলিউট রিফ্লেক্টরি পিরিয়ডের মধ্যে পড়ে গেছে, কাজে সেটা কার্যকর হচ্ছে না। কাজে এটা মেক কারেন্ট দিয়ে এরকমভাবে কার্ভটা করা হয়েছে। আর এটা হচ্ছে মায়োগ্রাফ বোর্ড, যার উপরে প্রিপারেশনটা রাখা হয়েছে। হ্যাঁ, বইয়ে দেখবে লুকাস বা এই সমস্ত ইয়ে আছে, সেগুলো সেগুলো এখন আর আউট অফ সিলেবাস হয়ে গেছে বলে এখানে আর সেখানে আর কেনাও হয় না। আর বাস্তব ক্ষেত্রে মায়োগ্রাফ বোর্ড দিয়ে, মায়োগ্রাফ দিয়েই করা হতো। এটা মায়োগ্রাফ বোর্ড, মায়োগ্রাফ স্ট্যান্ড আর একটা বেস, এবং এর সঙ্গে একটা এমন অ্যাপারেটাস থাকে সামান্য, যে যাতে এর যে এটা যেটা কীভাবে টাচ করে আছে সেটাকে ফিক্স করে রাখে, সেটার জন্য ওটা না হয়, মানে রাজবিদ, মানে টাচটা যেন কম বেশি না হয়, সেটা কন্ট্রোল করার একটা ব্যবস্থা আছে, থাকে। এখন এর মধ্যে এই প্রিপারেশনটা রয়েছে, এটা হচ্ছে গ্যাস্ট্রোনেমিয়াস মাসেল, আর এটা হচ্ছে তার কন্ডোরা বা টেন্ডন। হ্যাঁ, এটা হচ্ছে যে তোমার হচ্ছে এটা হচ্ছে গ্যাস্ট্রোনেমিয়া, এটা হচ্ছে তোমার, এটা হচ্ছে সায়াটিক নার্ভ, আর এটা হচ্ছে ভার্টিব্রাল স্টাম্প, মেরুদণ্ডের অংশ, সেটা ঝোলাতে সুবিধা হয়। আর এরপরে আমার মাঝে মাঝে স্যালাইন দিতে হয়, ফ্লক্স স্যালাইন দিতে হয়, যাতে ড্রাই না হয়ে যায়। হ্যাঁ, অ্যাম্ফিবিয়ান প্রিপারেশন, ব্লাড, এত কোনো ব্লাড সাপ্লাই নেই, তাহলে বেঁচে আছে কী করে, অক্সিজেন পাচ্ছে কী করে? জলের মধ্যে দ্রবীভূত, নর্মাল ভিতরে দ্রবীভূত অক্সিজেন রয়েছে, সেটা ডিফিউশনে ঢুকে যাচ্ছে, ব্যাপন প্রক্রিয়ায় ঢুকে যাচ্ছে, যার ফলে তাকে এই করছে, এবং ওটাকে হচ্ছে কি ওয়াশও করছে, যার ফলে যে ল্যাকটেট বা অন্যান্য যে পদার্থ উৎপন্ন হচ্ছে সেটাও ড্রেইন হয়ে যাচ্ছে, খানিকক্ষণ বাদে বাদে সেটা দিতে হয়। আর এটা হচ্ছে সিলিন্ডার, এবং এর উপরে ওই কাগজ লাগানো হয়, লেফট ফ্ল্যাটটা উপরে করে। হ্যাঁ, এবং এটা এখানে একটা লোড আছে, লোড স্ক্রু। এখন সার্কিটটা কমপ্লিট হবে কি করে, এখন এক্ষেত্রে সার্কিটটা এরকমভাবে আছে, যেইটাকে টাচ করবে সঙ্গে সঙ্গে এই বডির মধ্য দিয়ে সার্কিটটা কমপ্লিট হবে। এর জন্য মেক অ্যান্ড ব্রেক এটাতে পাওয়া যায়। এর অ্যারেঞ্জমেন্টের সাহায্যে ব্রেক কারেন্টও এখানে ডেমনস্ট্রেট করা যায়। এখন এই সেকেন্ডারি ইন্ডাকশন কয়েল যত কাছাকাছি আসবে তত বাড়বে, তত তার অ্যাম্পলিটিউড বাড়বে। খুব দূরে থাকলে পরে দেখা যাবে যে কোনো রকম নেই, মাসেল কন্ট্যাক্ট করছে না। কেন করছে না, সেটা হচ্ছে সাব থ্রেশোল্ড স্টিমুলাস। এই যে পেরিফেরাল নার্ভ যেটা আসছে সেটাকে, এটা হচ্ছে লোয়ার মোটর নিউরন সমস্ত। পেরিফেরাল নার্ভ থেকে একটা সিঙ্গেল অ্যাকশন তো থাকে না, হাজার হাজার অ্যাকশন আছে, সেগুলো বান্ডেল তৈরি হয়। পেরিফেরাল নার্ভের গঠন তোমার, এটা অ্যানাটমি বইয়ে, হিস্টোলজি বইয়ে তোমাদের এটা কাজে লাগবে। একদম বাইরে থাকছে এপিনিউরিয়াম, তারপরে ভিতরে যে বান্ডেল তৈরি করছে সেটা হচ্ছে পেরিনিউরিয়াম, আর ইন্ডিভিজুয়াল অ্যাকশনের বাইরেও দিকে কানেক্ট টিস্যু থাকে, সেটা হচ্ছে এন্ডোনিউরিয়াম, এরকমভাবে থাকে। কাজে এটা যখন অনেক দূরে থাকবে তখন দেখা যাবে যে কোনো নেই, কোনো রকম মাসেলটা কন্ট্যাক্ট করছে না। তার কারণ যে নার্ভটাকে সে স্টিমুলেট করতে পারছে না, সাব থ্রেশোল্ড বলে। যখন কাছাকাছি জায়গায় যখন যাবে তখন দেখা যাবে যে এটার প্রথমে উইক কন্ট্রাকশন হবে, যত সন্নিকটে যাবে তত বেশি হবে, তারপরে এক সময় দেখা যাবে সেটা চূড়ান্ত পর্যায়ে পৌঁছে গেছে, আরও কাছে নিয়ে গিয়ে আর কোনো লাভ হবে না। তার মানে হচ্ছে রিক্রুটমেন্ট অফ মোর অ্যান্ড মোর মোটর ইউনিট আছে, মোটর ইউনিট, বুঝতে পারছো? মোটর ইউনিট কাকে বলে? মোটর ইউনিট বলো, কত রোল তোমার? হ্যাঁ, কত রোল? হ্যাঁ, 90। হ্যাঁ, তাহলে মোটর ইউনিট কাকে বলে? মোটর ইউনিট ফার্স্ট নিউটন। এরকম উত্তর করলে পরে সে তোমার কে পাস করাবে? হ্যাঁ, সেই, বুঝতে পারছো? এইরকম প্রশ্ন উত্তর শুনলে পরে তো কী করবে? আর যেরকমভাবে চারপাশে ডেভেলপমেন্ট হচ্ছে, এতে তো আমারই ঢুকতে ভয় করে যে কত বড় একটা ইনস্টিটিউশন তৈরি হবে এরপরে, বুঝতে পারছো তো? এরপরে এখানে আসবার জন্য এক্সামিনারদের পড়ে যাবে যে আমরা যাই, এত বড় একটা প্রতিষ্ঠান তৈরি হয়েছে, তা সেখানে যদি এরকম উত্তর আসে তখন তারা কি ভাববে? হ্যাঁ, তাই না? পর্বতের মুশিক প্রসব হয়েছে, সেটা সেরকম ভাববে। হ্যাঁ, এবং নম্বর আসবে না। সেই জন্য কিছু কিছু তোমাকে জানতে হবে। মোটর ইউনিট এটা তোমার শর্ট নোট হিসেবে আসতে পারে। পরে কিছু সময় পাওয়া গেলে তোমাদের ইউনিভার্সিটি পরীক্ষায় যে প্রশ্নগুলো এসছে, এটা আমি এই সকালে প্রথম দিকটা কিছু কিছু আলোচনা করে দেবো 10-15 মিনিট, সেটা তোমাদের সুবিধা হবে, বুঝতে পেরেছো? পাস করতে সুবিধা হবে। এই মোটর ইউনিট মানে হচ্ছে একটা লোয়ার মোটর নিউরন, মনে করো অ্যান্টেরিয়র হর্ন সেল থেকে, স্পাইনাল কর্ড থেকে, হ্যাঁ, একটা অ্যাকশন বেরিয়েছে, সেটা ডিভাইড করছে, ডিভাইড করে মাসেল ফাইবারগুলো যাচ্ছে। সেখান থেকে যখন অ্যাকশন পোটেনশিয়াল যাচ্ছে নার্ভ দিয়ে, তখন ওই গোষ্ঠীভুক্ত যত আছে সবই কন্ট্যাক্ট করছে। কাজে ওটাকে যে ইউনিট হিসেবে বলছে মোটর ইউনিট। ইন হেলথ প্রত্যেকটা যে কটা ব্রাঞ্চে যাচ্ছে, সেখানে 100টাও হতে পারে, ক্ষেত্র বিশেষে 5টাও হতে পারে। সেখানে যে কটা মাসেল সেল প্রত্যেকটাই সেখানে কন্ট্যাক্ট করবে নর্মালি, কারণ নার্ভ দিয়ে যখন পেরিফেরাল নার্ভ দিয়ে যখন যাচ্ছে, তখন তার আর কন্ট্রোল করার ক্ষমতা নেই। কন্ট্রোলটা সেন্ট্রাল নার্ভাস সিস্টেমে। সেন্ট্রাল নার্ভাস সিস্টেমে যে সেলগুলো রয়েছে, সেগুলো অ্যান্টেরিয়র হর্নে থাকছে, মোটর নিউরন, এবং তার উপরে নানা রকম অ্যাকশন আসছে, উপর থেকে আসছে, আর অন্যান্য জায়গায় রিফ্লেক্স দিয়ে হচ্ছে, বুঝতে পেরেছি তো? এই সমস্ত জায়গায় হচ্ছে। কাজে সেইখানে কন্ট্রোল আছে, যে বিচার বিবেচনার ক্ষেত্র সেইটা। কিন্তু সেখান থেকে যখন একবার বেরিয়ে গেল, তখন আর কিছু করার নেই, বুঝতে পেরেছো জিনিসটা? হ্যাঁ, সেখানে গেলে তোমার আর কিছু করার নেই। একবার অ্যাকশন দিয়ে যদি কোনো একটা ইম্পালস যায়, তার সংলগ্ন যে মাসেলগুলো, সেগুলো সবসময় ইনভলভ হবেই। ভাবিয়া করিও কাজ, করিয়া ভাবিও না, বুঝতে পেরেছো? সেক্ষেত্রে সেই রকম জিনিসটা এখানে সিস্টেমটা রয়েছে। যে তুমি মনে করলো যে একটা লোককে গালাগালি দেবে ভাবছো, তারপরে ভাবছে যে না, গালাগালি দেওয়া সেটা মোটরের কাজ। হ্যাঁ, তারপরে তুমি লোকটা গালাগালি দিলে না, তার মানে কি সেখানে তোমার বিবেক বুদ্ধির জয় হলো। কিন্তু তোমার যদি ক্রোধ বেশি থাকে সেই লোকটার উপরে, তখন তুমি কিছু একটা কটু কথা বললে, সে হয়তো বললো, তখন তুমি এরকম বলছো কেন, এইরকমভাবে বিবাদ উৎপন্ন হয়। কাজে তোমার এই যে বিচার বিবেচনাটাই হচ্ছে প্রধান জিনিস। তারপরে সেটার উপরে একবার যখন অ্যাকশন দিয়ে চলে গেল, আর তোমার কিছু উপায় নেই। সেখান থেকে সাফিসিয়েন্ট নিউরো ট্রান্সমিটার বেরোবে, এবং তার সংলগ্ন যে যতগুলো অ্যাকশন আছে সব জায়গায় তার মানে মাসেল সেল আছে, প্রত্যেকটাই কন্ট্যাক্ট করবে। এবং ওই জায়গাটা খুব ইম্পর্টেন্ট, নিউরোমাস্কুলার জাংশন, স্কেলেটাল মাসেলের নিউরোমাস্কুলার জাংশন, মোটর ইউনিটের খুব ইম্পর্টেন্ট পরীক্ষায়, এবং এটা একটু জানাও দরকার। খুব সহজ জিনিস, কে একবার যদি একবার বইতে বাড়িতে ভালো করে পড়ো, তখন তুমি ভাববে যে এই সমস্ত ক্লাসে আলোচনা করার কি দরকার ছিল, আমাদের তো অনলাইনে জানিয়ে দিলেই হতো এখন, হ্যাঁ, এরকম ভাববে তখন। কিন্তু তোমাদের যেটা জানতে হবে এটা, কারণ এই যেটা বলতে পারছে না, এর মধ্যে কোনো রকম লজ্জা নেই, এগুলো পরীক্ষার জন্য ইম্পর্টেন্ট। কাজে আজকে সময় খুব কম আছে, তোমরা ওখানে গিয়ে প্র্যাকটিক্যালটা করো। আজকে তোমার কী চলছে? হেমাটোলজি চলছে না তোমাদের? হেমাটোলজি চলছে তো? হ্যাঁ হ্যাঁ হ্যাঁ, WBC। তা মানে একটা জিনিস যতবার চর্চা করবে তত তোমার হবে, শিখবে। হ্যাঁ, প্র্যাকটিস মেক্স পারফেক্ট। আর রোজ সবাই আসে না, রোজ সবাই মন থাকে না, কিন্তু আজকে তোমাদের জন্য একটু নতুন নিয়ম করা হয়েছে, আগে করা উচিত ছিল। যে তোমরা মনে করো 5জন 6জন একটা করে গ্রুপে করছো, একজন মাইক্রোস্কোপটা নেবে এবং হিমোসাইটোমিটার, তোমার রোল নাম্বারটা থাকবে। মনে করো তোমার রোল নাম্বার তুমি নিয়ে তোমার দায়িত্ব থাকবে এটাকে যথাযথ ফেরত দেওয়ার। সবাইকে তো আমাদের পক্ষে গরু খোঁজা করা সম্ভব না, কাজেই ওটা দেখবে। এবং কোনো মনে করো কাজ করতে গিয়ে দেখলে মাইক্রোস্কোপটা কিছু কালার ঠিক মতন আসছে না, হয়তো ফাঙ্গাস হয়ে গেছে, অবজেক্টিভ আইপিস নাড়িয়ে তুমি বুঝতে পারবে প্রথমেই যে এর মধ্যে কিছু অসুবিধা রয়েছে। তাহলে তার পরিবর্তে ভালোটা নেবে, আর যেটা খারাপ আছে আমাদের সেটা জানাবে। জানার পরে আমরা সেটাকে আলাদা করে রাখতে পারবো। করলে পরে আলমারিতে আলাদা করা থাকলে পরে আমাদের সেটা সুবিধা হবে, যে ক্লিন করতে আসবে আমি চিঠি লিখে দেবো, সে ক্লিন করতে আসলে পরে সে সেগুলো নিয়ে কাজ করতে পারবে। কাজেই তোমাদের সামান্য কাজ, এটা সর্বত্র এরকমভাবেই হয়, এরকমভাবেই হয়। একজনের নামে হয়তো 5-6 জন কাজ করছো, একজন এসে তার রোল নাম্বারটা লিখে দেবে যাবে এবং সেখানে এবং তার দায়িত্ব থাকবে এটাকে যথাযথ ফেরত দেওয়ার। তারই যে আসতে হবে এমন কথা নয়, সেও তাই জন্য তুই এটা ফেরত দে, এবং সে ঠিকমতো যেন ফেরত দিয়ে যায়। আমার কথা বুঝতে পেরেছো তো? কাজ করতে গেলে ভাঙতে পারে, সেটাও তাতে কিছু যায় আসে না। হ্যাঁ, কিন্তু তোমাদের এইটা চালু করা হলো আজকে থেকে, তোমরা এটা সই করে নেবে আবার ফেরত দেবে, আর যেমন প্র্যাকটিক্যাল করছো। আর সময় থাকলে যদি আরবিসি কাউন্টটা যদি মনে পড়ে, তাহলে বলছে সময় থাকলে আরবিসি কাউন্টটা একটু প্র্যাকটিস করে নেবে। তোমাদের কাছে হিমোসাইটোমিটার আছে, দুটো পিপেটি আছে, ডাব্লিউবিসি কাউন্ট করে মনে করে যদি তোমার জ্ঞান হয়েছে যে না আমার ফোকাস করা, এই কাউন্ট করা, এগুলি সম্বন্ধে আমার যথাযথ জ্ঞান হয়ে গেছে, তোমার এরকম যদি উপলব্ধি হয়, তাহলে বলছে না অবশ্য সময়টা তুমি তো করলে। আর হয়ে গেলেও তোমার যতগুলো ক্লাস পড়বে তত তোমার কনফিডেন্স বাড়বে। কাজে পরীক্ষার সময় তোমার নতুন কিছু মনে হবে না, ইউনিভার্সিটি পরীক্ষার সময়। তাহলে আজকে এই অবধি থাক, এর পরের দিন আমরা অন্যগুলো করব। হ্যাঁ, এফেক্ট অফ রিপিটেড ইন্ডাকশন শক, ফ্যাটিক, অন্যান্য যে পার্টগুলো আছে, লোড, এগুলো তোমাদের আলোচনা করে দেবো।
Okay, today new topic is the posterior compartment of the leg. Okay, or the back of the leg. Okay, so at first tell me which are the bone present on the back. Posterior, this is the posterior part of the leg. Okay, so on the posterior compartment of leg we are having tibia and fibula, and in between that there is intramuscular septum. Okay, so another thing which is differentiating the tibia and fibula, there is one transverse septum, okay, present on the posterior side. Okay, so write it down, the posterior, everyone please be quiet. Today I will explain, tomorrow we will see the parts, okay, parts of the muscle. Okay, so write it down, the posterior compartment of leg. The posterior compartment of leg consists of two part, superficial and deep, superficial and the deep. Okay, so how it is differentiated? There is one layer of deep fossa, write it down, there is one transverse layer of deep fossa, there is one transverse layer of deep fossa which intervenes between them, okay, superficial compartment and the deep compartment. So first of all, if you see the superficial compartment, how many muscles are there? These muscles are also known as ki bole, these are the calf muscles. Okay, calf muscles. So which are they? So mainly 3 muscles. So write it down, superficial compartment consists of first one is gastrocnemius. Okay, number 1 is okay. So these gastrocnemius having 2 head, one is medial, another one is lateral. Now tell me which one is the larger, medial or lateral? Do you know which one would be larger? The medial head. Okay, how you could identify the side, but you have to know medial head is much larger, okay, than the lateral head. So these gastrocnemius having 2 head. Then second one is soleus. So why it is called soleus? It is looking like a sole or the feet, okay. And the third one, that is known as plantaris. Okay, so these are the 3 muscles present on the superficial compartment. Okay, now write it down one by one. Number 1, we will discuss about gastrocnemius. Okay, so it is having 2 head, medial and the lateral head. Okay, medial and the lateral head. So at first write it down, medial head origin is from, who will tell me medial head origin? This is the femur. Okay, so at the lower part, it has got two condyle. Which one is the medial condyle? This is the medial condyle. This is the lateral condyle. So you write the posterior superior aspect of the femur. It is very much important. Although it is a muscle of the leg, but it is takes origin from the femur. Okay. So write it down. Posterior superior aspect of medial condyle of femur. Okay, insertion I will tell you later, and here you include, this is the larger part. This is larger than the lateral head of gastrocnemius. This is larger, much larger than the lateral head of gastrocnemius. What about the lateral head? Write it down, lateral head. Now see what is the difference between the two. This is the posterior surface of femur, right? So you are having, this is the medial condyle, this is the lateral condyle. I told the medial head is coming on the posterior superior aspect. But what about the lateral head? Lateral head, if you see on the lateral surface of lateral condyle, there is one presence of groove. Okay, and there is one presence of small pit. Okay, so there are two things, that is the attached. So which thing is present on the groove? Groove e ki thake? Who will tell? Femur is already over, na? So on the this medial side, we are having erector tubercle just above the medial condyle, right? Lateral side keep up a groove for popliteus, tendon of popliteus. So write it down. The lateral head take origin from, here you have to mention lateral surface of lateral condyle. Lateral surface of lateral condyle. So it would be above this tendon of popliteus. Okay, above the tendon of popliteus. A groove tendon of popliteus run korbe, above superficial there would be lateral head of gastrocnemius. What about this small pit? Which thing is attached over here? Do you know? Knee joint is over? No. Over. So which thing is attached? Lateral collateral ligament. Write it down. Small pit, there is an attachment for lateral collateral ligament of the knee joint. Okay, lateral collateral ligament of knee joint. Okay, so now you understood the two different origin. Okay, lateral and medial head. What about the characteristic of this muscle? Is it unipinnate, bipinnate or multipinnate? Gastrocnemius? It is bipinnate. Okay, maximum all the muscle present on the flexor compartment of the leg is bipinnate. Except why? It is except the soleus, because it is the multipinnate muscle. Okay, so in the upper limb we have seen which one is multipinnate? Deltoid. So same like that we are having the soleus. It is having multipinnate structure. Okay, so that is the nature of the gastrocnemius. Now it is coming to the insertion. So write it down, the insertion. It is inserted on the kothay insertion of it? So it will form the triceps suri. Okay, write it down. It will form the triceps suri. Now what is triceps suri? These two are the two head, medial head and lateral head. Which one is the third one? Which part of the soleus? The soleus is divided into two parts by anterior lamella and posterior lamella. So posterior part of the soleus unite with this two tendon of gastrocnemius. Understood? So together it is known as triceps suri. Write it down, triceps suri. Okay. So you write, it is inserted, both the head inserted along with the posterior part of soleus as tendoachilles, as tendoachilles. Where does it got inserted? Which part? Calcaneus, which part? Posterior surface, I told inferior area, right? If you could remember the calcaneum, superior e ki thakbe? There is presence of fibrofatty tissue. Okay, so it would be inserted over here. Okay, both this gastrocnemius and the posterior part of the soleus. This is known as triceps suri. Triceps suri may comes also as a short note. Okay, sometimes it used to come as short note. Explain the triceps suri. Okay, then the next muscle we are having, that is the soleus. Okay, so write it down, soleus. নার্ভ সাপ্লাই রে বলছি, একদম লাস্টে বলবো, সব তো সেম। ওকে, সো সোলিয়াস, about the soleus, origin is, there are three origin. Okay, write it down. Number one origin is, where its origin? First origin is soleal line of tibia. Number one origin is, this is the soleal line. Okay, soleal line of the tibia. Okay, then the second one, see, this is the upper part of fibula. Okay, so on the upper part, write it down, head. Which surface? It would be which surface? Tibia dike hobe. Okay, so medial surface of the head of the fibula, medial surface of the head of the fibula, and also the upper 1/4 of fibula, upper 1/4 of fibula, there would be origin of soleus. Okay, তাহলে একটা origin is coming from tibia, another from the fibula. Fibular কোথায়? Head, medial surface of the head, and also the upper 1/4. Okay, and rather than that, another origin is, no, soleal line of tibia is over. So this is the posterior surface. So between the tibia and fibula, you are having the interosseous membrane. So there is a formation of arch. Okay, so write it down. Third origin is arch between the interosseous membrane of tibia and fibula. Interosseous membrane of tibia and fibula. Okay, now see, there is interosseous membrane between the tibia and fibula, right? So there is one gap in there on the superior aspect. Okay, some vessels and nerve are going posteriorly, some are coming anteriorly. Anteriorly, which are the vessels and nerve? Nerve ta ki ache bol? Anterior compartment. What about the deep peroneal nerve? Deep peroneal nerve, no? And which artery? তোরা ভুল বললি, anterior tibial artery. Anterior tibial artery and deep peroneal nerve. So that is the anterior aspect. What about the posterior aspect? Write it down. Posteriorly, two structure piercing the interosseous membrane. Two structure piercing the interosseous membrane. Okay, and it is coming out to give supply the posterior compartment. It will give supply the posterior compartment of the leg. So which are the two structure? Number one, main division of sciatic nerve, main subdivision of sciatic nerve, that is the tibial nerve. Okay, that is the tibial nerve. What would be the root value? এটা আমি ভেবেছিলাম S1 S2 হবে শুধু। ওকে, রাইট ইট ডাউন, S1 S2। ওকে, S1 আর S2 এই দুটো হচ্ছে চিফ কম্পোনেন্ট অফ টিবিয়াল নার্ভ, S1 and S2। ওকে, দেন which artery is there? That is a popliteal artery coming on the popliteal fossa. So it is dividing into two artery. One is going anterior tibial artery, posteriorly would be coming posterior tibial artery. So write it down. Second structure is posterior tibial artery. Second structure is posterior tibial artery. Okay. Now the thing is that where you have to trace. Okay, suppose if you are dissecting, first thing you will get what? Skin superficial fossa, then you will get deep fossa, then you will get fifth thing, that is the capsule of knee joint. Okay, so after cutting the capsule you are having this muscle that is known as gastrocnemius. Okay, so after gastrocnemius you are removing the head, medial and lateral head, in between that you will have the soleus. Okay, so how to identify the soleus? The pattern of the fibers would be reddish. Okay, whereas gastrocnemius it would be white fibers. Okay, so if we describe what is the difference between white and red fibers, which would be more faster? You know? White. White would be most faster. Okay. Red fibers means the circulation is more over there. Okay. So I will discuss what is the kinetic action of these three muscles. Okay, because it is very much active while we are walking, any running, okay, walking, the propulsion of foot. Okay, so that is very much important. So where we are in the two structure, remember, one is the posterior tibial artery, another one is the tibial nerve, not anterior tibial nerve. Tibial nerve one, that will only supply all the muscles, superficial and deep, of the posterior compartment of the leg. Okay. Now, what are the features of soleus? Next, write it down. What is peripheral heart? Why the soleus? This question used to come again and again. Why the soleus? Soleus is also known as peripheral heart. Okay, soleus is also known as peripheral heart. So, what is the reason behind it? So, first thing you have to write it down. The superficial vein. The superficial vein of the posterior compartment of leg is কি vein আছে? Great saphenous vein. Okay, great saphenous vein. Okay. So from here, write it down. From here, numerous deep veins will connect. Deep veins will connect and pierce the soleus. Okay, pierce the soleus. Okay, and what is the nature of this vein? Write it down. It does not have any valves. Okay, it does not have any valves. Okay, so suppose if there is no valves, what will happen? Varicose vein. Back flow would be prevented or black flow will be there? Which one? Will be there. Main action of the valve is to prevent the black flow. Okay. So write it down. There is a formation of venous network. There is a formation of venous network around the soleus. Around the soleus. So, whenever there is contraction of this soleus, it squeezes the venous blood. কিরকম হবে? It will squeezes the venous blood towards the heart. Okay, towards the heart. What is the direction of this circulation? এই সার্কুলেশনটাকে কি বলে? Centripetal. Okay, এবার একটু বোঝ, there is two type of circulation. One is centripetal, আরেকটা হচ্ছে centrifugal. Okay, centripetal হলে কি হবে? It is coming from the periphery. Okay, it is coming from the your this hand or the feet or the leg or the forearm. Okay, it is going where? To the central of the trunk. But centrifugal means the circulation of heart. Central থেকে বাইরের দিকে আসবে। তার মানে এখানে you have to remember it squeezes the blood centripetally. Okay, towards the heart. Okay, so that's why it is known as peripheral heart. Okay, exactly if this explanation you will write, you will get more marks. Okay, so this is about the peripheral heart, why the soleus is called peripheral heart. Okay, then the next one is, what about the insertion of soleus? What about the insertion of soleus? Posterior lamella is going to the triceps suri. Write it down. Posterior lamella is continuing with the triceps suri with the two head of gastrocnemius. Then what about the anterior lamella? Anterior lamella. Soleus তো exactly এই পোর্শনটাই থাকে, তাই তো? So is it also having any attachment to the fibula? It is having any attachment to fibula? থাকে. Okay. So if you could remember this surface, posterior surface of fibula, there is also attachment of soleus. Okay. So it is inserted. Write it down. It is inserted on the posterior surface of upper 1/4 of fibula. Posterior anterior lamellata. Okay, which is attached to the bone. Okay. Okay. So this is these two gastrocnemius and soleus. Third muscle I told, that is, write it down, that is the plantaris. Okay. So how to identify the plantaris? At first tell me the origin. Just now I said origin কোথা থেকে হবে? This is the medial condyle, this is the lateral condyle. So what will happen? This tendon of plantaris will take origin from the lateral surface of lateral condyle of femur. Okay, write it down. The tendon of plantaris takes origin from exactly এই পয়েন্টটাই হয়, ঠিক আছে? If you draw, this is the attachment of plantaris. Okay. So it is the lateral surface of lateral condyle of femur. Then what is happening? It will take origin from here and then it will coming to the medial side. Okay. So write it down. Then it comes to the medial side and run downwards. If I will trace what? At first the lateral head of gastrocnemius. Below that you are having the tendon of plantaris. Then you have to also remove. Okay, so write it down. For getting the tendon of plantaris, you have to remove the medial head of gastrocnemius. Okay, you have to remove the medial head of gastrocnemius. Okay, and it is also looking like a nerve. Okay, you could not exclude that it is a tendon or a nerve. Okay, and it is also known as rat tail muscle. Okay, rat tail muscle. Okay, but remember, plantaris won't take part or participate to formation of tendo Achilles. Plantaris won't take part in the formation of tendo Achilles. But again it is inserted where? It is inserted on the posterior surface of calcaneum. It is inserted on the posterior surface of calcaneum. And it is also known as freshman nerves. Write it down. It is also known as freshman nerves. Okay, freshman, fresh. The body is fresh because it is looking like a nerve. Okay, it is looking like a nerve. Okay, newly dissected body, you could not differentiate between the nerve and the plantaris. Okay, then next one we are coming to the deep group. Same. Palmaris longus ke bola hoy na, but it is only found on 10% cases. তাই না, টেন্ডনটা পাওয়া যায় রিজেনারেটেড। Okay, so we just write. Next one is the deep muscles. Okay, deep muscle on the flexor compartment. So which are the muscle? Number one is popliteus. Okay, write it down. Popliteus. Okay, second one ki pabe flexor group e pabe. So flexor group, first one is flexor hallucis longus. then flexor digitorum longus, then third one is tibialis posterior. Okay, so these are the 4 muscle you will get on the deep compartment. Okay, and remember, for getting the deep compartment you have to cut, ki katte hobe? The capsule of knee joint, write it down. To get the muscle of the deep compartment, you have to cut the capsule of knee joint. The capsule of knee joint. So first one we will discuss, that is the popliteus. Okay. So if you see the popliteus, what would be the origin? It is a triangular muscle. Okay. It is not diamond shape. Remember, it is a triangular muscle which is forming the floor of popliteal fossa. So write it down. It's a triangular muscle. It's a triangular muscle, and it is forming the floor of the popliteal fossa. It is forming the floor of the popliteal fossa. And the most important characteristic of this muscle is it is intracapsular extrasynovial. Okay. Most important feature of this muscle is intracapsular extrasynovial. Okay. Which are the other characteristic? Another one is it is also known as unlocking muscle. Okay. It is also known as unlocking muscle. Now all of you are sitting here. Okay. So what is the position of the knee? Unlocked. Okay. Whoever is standing, it is locked. Okay. So write it down. Unlocking of knee occurs during sitting position. এটা কিন্তু খুব ভালোভাবে খেয়াল রাখবে, আনলকিং কখন হয়? সিটিং or whenever you are flexing the knee. ঠিক আছে, কেউ ফুটবল খেলার জন্য শর্ট ইয়ে করবে, that time also unlocking must be done. Okay, locking and unlocking. Okay, so this unlocking muscle, this function would be done by popliteus. Now coming to the origin, write it down, origin. So origin কোথা থেকে নেবে? দুটো পার্ট. So this is what, this is the see, medial side and lateral side. So both the line, lateral and medial supracondylar line of femur. Write it down. Or you could write popliteal fossa of femur. Okay, popliteal fossa of femur. এই সারফেসটাকে, triangular সারফেসটাকে আমরা popliteal fossa বলি. Okay, popliteal surface of femur. Medial and lateral supracondylar line and the popliteal fossa of femur. Okay, and insertion. What about the insertion? Tibia where? Above the soleal line. Okay, above the soleal line. Okay, and nerve supply would be the same, the tibial nerve. And function I told, what would be the function? Main thing is unlocking of the knee joint. Okay, then the second muscle we are having, which one we will discuss first. First one is, so there are 3 muscles. Okay, now you have to tell me the bony attachment. Okay, flexor hallucis longus is attached to which bone? Already tibia and fibula is over. Flexor hallucis longus. Tibia te attached hoy na fibula te attached? Fibula te attached hoy. Write it down. It is attached on the fibula. Just আমি attachment টা বলছি. Okay. Then what about the flexor digitorum longus? Flexor digitorum longus would be attached on tibia. On the tibia. Then what about the tibialis posterior? Both tibia and fibula and the interosseous membrane. Okay. So tibialis and posterior would be both tibia and fibula and the interosseous membrane. Okay. So now one by one muscle we will discuss. So you just remember this one, flexor hallucis longus on the fibula, flexor digitorum longus on the tibia, and tibialis posterior, both tibia, fibula and interosseous membrane. Okay. So now write it down, flexor digitorum longus. Flexor digitorum longus. So at first tell me the origin. I told tibia. So where? This is the tibia. So where? This part is occupied by the popliteus. This part is occupied by the soleus. But this part, so that is which surface? Lateral surface. Lateral surface on the posterior part of the tibia. This complete part would be occupied by the flexor digitorum longus. Okay, flexor digitorum longus. And another one is, it would be insertion. Insertion ta kothay hobe? Insertion of the flexor digitorum longus. So same like it will be inserted to the 4 digits. Okay, it would be inserted to the 4 digits. Where? Suppose this is the digit. So except the first one, it will be inserted remaining 4 digits. So second, third, fourth, fifth. Okay, and it will form what? কি বলে ওটাকে? Dorsal digital expansion. Okay, DDE, dorsal digital expansion. Okay, and remember it will merge. Write it down. It will merge during insertion. During insertion, it will merge along with the flexor tendon of flexor digitorum brevis. It will merge the tendon of the flexor digitorum brevis. Okay. Then the next one is flexor hallucis longus. So flexor hallucis longus, if you see the origin, where it will be originated, which part? If you could remember the posterior surface of the posterior aspect, এটাকে কি বলে? এই গ্রুপটাকে কি বলে? Medial group or medial sulcus. It would be occupied by which nerve? Peroneal nerve. Okay, and the peroneal artery. Okay, and this side whole there would be complete origin of the flexor hallucis longus. So write it down. তাহলে এটা যদি medial side হয়, এটা lateral side. Okay, so write it down. Lateral surface of posterior aspect. Lateral surface of posterior aspect. Upper 2/4. Upper 2/4 of the fibula. Lower 1/4 কি থাকবে বলতে পারবি? এই এরিয়াটা পুরোপুরি occupied by flexor hallucis longus. So lower এরিয়াতে কি থাকবে? Flexor digitorum brevis. Okay, lower part would be occupied by the flexor digitorum brevis. Okay, what about the insertion? Insertion কোথায় হবে? To the great toe. Okay, to the, so you have to say on the anatomical term, it is on the first proximal phalanx and first metatarsal. Okay, so then the next one is we are having the tibialis posterior. Okay, so origin would be, I told, it is taking origin from tibia and fibula. So from tibia where? From tibia where? Toward the medial malleolus or lateral malleolus? মানে lateral side, কোন সাইডে হবে? Lateral side, কারণ it has to take also origin from the fibula and the interosseous membrane, so it would be present in between. Okay, so write it down. On the lateral surface of the posterior aspect of tibia. And if you could remember the fibula, where it was the attachment, tibialis posterior, এই পার্টটা already occupied. Then yeah, medial surface, okay, medial surface or posterior aspect of fibula, okay, and the third origin is from the interosseous membrane. Interosseous membrane, there would be formation of one arch, bony arch, okay, between the tibia and the fibula, okay. Then write it down about the insertion. Insertion is very much important in case of tibialis posterior, okay. So tell me the insertion. Tibialis posterior insertion. It is also key muscle boli ammi etake inverter, right? Inverter of the foot. So where it would be inserted?
medial side first proximal lines এর নিচে
কি বলেছিলাম, টিবিয়ালিস অ্যান্টেরিয়রটা কি করে যায়, পোস্টেরিয়রটা কি করে যায়? টিবিয়ালিস অ্যান্টেরিয়রটা অ্যান্টেরিয়র সারফেসে যায়, okay, then it would be crossing the area and it would be inserted where? Inferiorly, it will go inferiorly, then it will insert on the way to, and tibialis posterior will insert to the fifth metatarsal, okay, on the little finger, okay. So now about the tibialis posterior, the nerve supply would be the same, okay, the tibial nerve and the root value is S1 and S2. Now one very important thing, write it down, what is flexor retinaculum, okay, which one is the flexor retinaculum, okay. So flexor retinaculum attachment ta kothay hobe bol? So two things you have to know, one of the attachment, superior attachment, you write superior attachment on the medial malleolus, border of the medial malleolus, okay, and inferior attachment ta kothay hobe? Medial surface of calcaneum, medial surface of calcaneum. So it is present like a band over here, okay. Now you have to know which are the structure coming to the foot from the leg, okay. So there is how many tendon? Popliteus আসছে না, তাই তো ডিপ গ্রুপে আর কি টেন্ডন আছে? These three tendon, okay, one by one. Now you have to know the relation, okay. For knowing the relation, which thing you have to know? এটা কি? ক্যালকেনিয়ামের এই পার্টটাকে কি বলে? মিডিয়াল সারফেস, মানে টুয়ার্ডস দ্য মিডিয়াল ম্যালিউলাস, sustentaculum talli, okay. So here is the key point is sustentaculum talli. So write it down. First tendon is tibialis posterior. Tibialis posterior passes, the tendon of tibialis posterior passes superior to the sustentaculum talli, okay. Then next tendon is flexor digitorum longus. So flexor digitorum longus runs medial surface of sustentaculum talli, okay. Flexor digitorum longus runs medial surface of sustentaculum talli, and inferiorly on the medial surface of this sustentaculum talli there is presence of one groove. So that is occupied by tendon of flexor hallucis longus, okay. So write it down, the flexor hallucis longus runs inferior to the groove of sustentaculum talli, okay. So these are the relation, how these three things are passing to the flexor retinaculum. Rather than that, which structure will come? কি যাবে? Posterior tibial artery, okay, and another one is tibial nerve, okay. These are the component of the flexor retinaculum, and you all know what is the definition of flexor retinaculum. So it's a condensation of the deep fossa or band like fossa which will just cover this all tendons, okay, all the running structure, okay. Now about the function, which thing I skips about the function, so write it down about the function of all this muscle one by one. So first one, tell me gastrocnemius, what would be the function? Number one function would be key function hoy if we this plantar flexion or dorsiflexion, flexion of the leg, okay, flexion of the legs, that's okay. So write it down, flexion of the leg, number one, flexion of the leg, then plantar flexion of the ankle joint, plantar flexion of the ankle joint, and you all know the process of walking, okay, process of walking. So which action would be done by gastrocnemius? Propulsion, okay. So write it down, propulsion during walking or running, propulsion during walking and running would be done by two muscles, the medial and lateral head of gastrocnemius, and another one is soleus, okay. Now tell me, if you are running very fast, okay, or running, in case which muscle will act? I told white fibers present on the gastrocnemius, so at that time which will act? Gastrocnemius, okay. And if somebody is going slowly, so in that time which muscle will act? Soleus, just opposite, okay. So rather than that, which are the other actions? Suppose anybody is tiptoeing, tiptoe hoy to, tiptoe walking, toe walking jetake bole. So at that time toe walking, at that time of toe walking, or you are taking the foot above the ground, right? So at that time also this gastrocnemius is having the function, okay. Then rather than that, what is the most important function? এটা কাকে ক্রস করে বল, অরিজিন কোথায়? লোয়ার এন্ড অফ দ্য ফিমার, so that means it is crossing the knee joint, so it is also having flexion of knee joint, okay. It is contributing or assisting the flexion of knee joint, okay. So এটা হয়ে গেল gastrocnemius. Then soleus, okay, you have to describe the peripheral heart, okay, rather than this natural action you have to elaborate. Now the third function is about remaining flexion. So I told you about the কার function বলেছে already, I have discussed the popliteus, okay, unlocking of the knee joint, okay. Then next one, these last three flexure. So that means flexor digitorum longus, flexor hallucis longus, and tibialis posterior. So just write it down, these three: flexor digitorum longus, flexor hallucis longus, and another one is tibialis posterior. These three muscles are bipinnate muscle. These three muscles are bipinnate muscle, okay. And it is also crossing what? It is also crossing the ankle joint. The three tendons are crossing ankle joint. So it is providing the flexion of ankle joint, and plantar flexion of the foot. And which are the anti-gravity muscle? The both head of gastrocnemius and the soleus togetherly known as anti-gravity muscle. Okay. So each and every muscle fibers having different function that you have to memorize, okay. So what are the muscle of the superficial group and the deep group, and which is the triceps suri, okay, peripheral heart, these are the thing you have to know, okay. And what is the relation of sustentaculum tali with this three tendon? কি বলেছিলাম, superiorly কে যাবে? tibialis posterior. At the medial surface কে যাবে? flexor digitorum longus, and niche below groove ke jabe flexor hallucis longus, okay. So these are the three different type of tendon, okay. Tomorrow we will dissect this all part, okay. The muscle, you could see how one by one layer it is present, okay. So for getting the plantaris, what you have to cut the medial head of gastrocnemius, okay, then only you could able to see if it is present, Okay.